So can we get started? Yes. Okay. Okay. Fine. I think there was a change in the, the videos link and all, so that's why we're waiting. So I think everything is sorted now. We'll get started. Okay. So what we were discussing till this point of time was regarding some examples of a typical obstructive and respiratory and restrictive lung diseases. Okay. Right. So the next one we are going to discuss about will be the topic of pneumonia. But before we go on to that, this is what I was talking about. Can you see that it's a very non-specific finding? If you look at it, you may find it not very typical. Okay, right? So what you are seeing here is some white areas in all these areas, like this, small white areas like this, very non-specific one only, but something looking like what these white areas are nothing but the calcification. Okay, and can you see it is something like the dripping of the candle wax? Can you see all these areas, the dripping of the candle wax? So that is why this is also called as a candle wax appearance. And I have already told you in which type of pneumoconiosis you will see the candle wax appearance. Candle wax appearance is very typical of which condition? Yes, it is very typical of asbestosis. Okay, that is what I have told. It is very typical of the asbestosis. Correct? Okay. Right. So let us start with the next topic. The next topic is something which is very important. Almost like every year, we get one question from the section of pneumonia. I think in pediatrics also, we are getting questions from pneumonia part. Even adults also, the pneumonia part is something which is very important. So I am going to tell you about the important aspects of this pneumonia. And after that, I will be discussing about pleural effusion and all. So that area is something which surely you will get one question from this particular section, pneumonia and pleural effusion. Pneumonia, of course, is very important. That is what I will be discussing first. So if any of you have any issues with the streaming of this video or any audio, please let me know now itself because we are getting started now. I hope everything is fine. Okay, I think it is fine for everybody as of now. So we'll get started. Okay. All right. Okay, so we will get started. So pneumonia is a condition which is characterized by infection and inflammation of the lung parenchyma. Okay, so it's basically, you can just remember it is infection of the lung parenchyma. Okay, infection of the lung parenchyma. Okay, so that is what it is, meaning of pneumonia. Now you can see there are different classifications of pneumonia which I have put up. This is strictly for exam purposes, where you get questions like that. Okay, right? Based on few things which I am going to put up little later. So first, anyway, I will just start with this classification called typical pneumonia, atypical pneumonia, and pneumonia in an immunocompromised host. Okay. Typical pneumonia is something which is characterized by the usual organism or what we call typical organisms. Generally, you can tell me pneumonia is commonly caused by bacteria or virus. First thing, it is almost always caused by the bacteria compared to the viruses. So pneumonia is a thing of bacteria. It's an infection of bacteria more than the virus. So what are the typical bacteria which are associated with the pneumonia in adults? Okay, you can see in the next page, I have divided the typical pneumonias into further categories. Can you see that further important categories? Can you see community acquired? Sorry, it is not have. It is C. C for community acquired pneumonia. Please make that change. It is called CAP or community acquired pneumonia. Then hospital acquired pneumonia is called nosocomial pneumonia, healthcare associated and ventilator associated pneumonia. See, what is the meaning of community acquired? Before coming to the hospital, patient has an infection that is called community acquired pneumonia. Okay. So in simple words, if you want to remember, patient who develops pneumonia before hospitalization, then it is called community acquired pneumonia. That means from outside the hospital, he has acquired maybe the place where he is staying or the place where he was working or some other area from outside he has acquired infection is called community acquired. Or within 48 hours, please note the word within 48 hours of hospital admission. Okay, within 48 hours of hospital admission, then also we can call it as community acquired pneumonia. Okay, so please remember. Okay, I will tell you the importance of this 48 hours later on, but just remember like this: before coming to the hospital, he has pneumonia, or within 48 hours of hospitalization, he has pneumonia. Then it is called community acquired pneumonia. The most common cause of this community acquired pneumonia in area, what is this? It is Streptococcus pneumoniae. Most common cause of this is Streptococcus pneumoniae. That's what you have to remember. The most common cause of this is Streptococcus pneumoniae. So please make a note of this. This is important. The organism name is important. Then what is hospital-acquired pneumonia? Meaning, at the time of hospital admission, he did not have pneumonia. During the hospital stay, he develops pneumonia, and it is typically remembered as more than or equal to 48 hours after hospital admission. then it is called hospital-acquired pneumonia. Okay, so what is the meaning of this? Inside the hospital only, he has acquired the pneumonia. That is what the timeline is more than or equal to 48 hours. Please don't forget this. And here, in this setting, the most common organism is slightly different. Any of you know that? Here, the most common organism is slightly different. It is, yes, okay, fine. So it is Staphylococcus aureus. Here it is Staphylococcus aureus. Don't forget this. In the hospital setting, the most common organism is Staphylococcus aureus. See, whenever I talk about an organism, it's always related to Indian scenario I am talking about. Okay, most common cause means it is always related to Indian scenario. Even the most common condition like that I am talking about is always related to Indian scenario only. So please keep this in mind. Then something called HCAP. This is something like a new term and a very important term also. Okay, new term and a very important term called healthcare associated pneumonia. Meaning it's not hospital I'm talking about. Okay, somewhere in the healthcare setting is the pneumonia associated. Now, how do we define this? It's something like this. The patient was admitted in the hospital and he is discharged. Today he's getting discharged. Within few days later, he develops pneumonia and comes back to the hospital. Then we can say like maybe due to some exposure in the healthcare setting, he has developed a pneumonia. Looks like a very vague definition, but nowadays it is becoming important for only one reason, which I'm going to tell you shortly. So the situation is like this. What is that? Patient was admitted in the hospital. He is discharged, and a few days later, he comes back with pneumonia to the same hospital itself. Think like this. We call it as healthcare associated pneumonia. What is the timeline after hospital discharge? He develops infection within 90 days. Very important. Within 90 days. So it is relatively a long time. Within 90 days of hospital discharge. Within 90 days of hospital discharge, if he is developing an infection, it is called healthcare associated pneumonia. Here again, the most common organism is Staphylococcus aureus. So something related to hospital settings, you can think of Staphylococcus aureus. That is what I'm trying to say. Now you can ask me, why should I know about this particular term? What is the importance? Anyway, it is pneumonia, I'm going to treat it only. The point to be noted is once a patient has developed an infection, after being in the hospital sometime in the past, it may be a high risk for some MDR pathogen. It is associated with increased risk of MDR pathogen. I hope you can understand what does this MDR stand for. It is multi-drug resistant pathogens. Very simple. Increased risk of multi-drug resistant pathogens. This is the importance. Please don't forget it. Increased risk of MDR pathogen. That is what I am worried about whenever I see a patient with HCAP. I hope you are able to follow this, right? I hope you're able to follow this. It is something like this. It is MDR pathogens which are very high risk. Okay, right. So this is for healthcare associated pneumonia. Fourth category is again one more important and a serious one also, something called ventilator associated pneumonia. Okay, maybe due to whatever reason the patient is put on ventilator. After putting on ventilator, he develops pneumonia, then it's called ventilator associated pneumonia. Here again, developing after 48 to 72 hours. Okay, after putting the patient in ventilator. Okay, for putting the patient ventilation, we put a tube inside, right? Endotracheal tube. Or I will write like this: after endotracheal intubation. After endotracheal intubation, more than 48 to 72 hours after endotracheal intubation, then we call it ventilator associated pneumonia. Here, the most common organism is slightly controversial also, but I will go according to what is given in most of the text. It is Pseudomonas. It is Pseudomonas. Okay, so you can see that in each of the settings, you get different types of organisms, right? In each of these settings, you get different types of organisms. You can see overall, this community acquired pneumonia, it is strep pneumonia. Okay, hospital acquired pneumonia, it is Staphylococcus aureus. Then healthcare associated pneumonia, again it is Staphylococcus aureus. Ventilator associated pneumonia, it is Pseudomonas. Can you notice that, right? These are all some important things. Now, next thing which I wanted to remember is the previous one. What is it? Atypical. Atypical, I will tell you why it is atypical. Based on the X-ray and clinical features, they are called atypical pneumonias. I will come to that little shortly. What is atypical about this? And this atypical is caused by something called atypical bacteria. Any of you know some examples of atypical bacteria? Okay, it refers to an infection caused by atypical bacteria. That's what I'm trying to say. Any atypical bacteria you know? Any atypical bacteria? Let me just see if any of you have answered that. Okay, fine. Atypical bacteria, typical example would be Mycoplasma. In this group, most important is the Mycoplasma. Please don't forget it. Mycoplasma pneumonia. I'm just writing the name only. Mycoplasma. Any other? Chlamydia. One more. Legionella. These are some typical examples of atypical bacteria. Out of this, the common group will be Mycoplasma. In the atypical bacteria group, it is Mycoplasma. Okay, fine. Okay. Now, what is the last category? In a patient with immunocompromised host, the best example of that immunocompromised status, I would put it up, is for the HIV infection. And I think even this time there was a question based on this HIV infection and pneumonia. Now, there are so many organisms which can cause. Okay. And based on the, let me see if I have given the space there. Just a minute. Yes. Can you see that little below? Little below. This space is there. Okay. You don't need to take it now. We will discuss that later. What you are going to write here is in a HIV compromised, immunocompromised host, the most common, please write that alone now. The most common would be in area, HIV infection, pneumonia. What is the commonest organism? Yes, it is chlamydia. Okay, you have said that. And that is for atypical. What about here? Here it is pneumocystis. It is pneumocystis. Pneumocystis. I think all of you know the new name of this. It's called pneumocystis jirovecii. That is the infection. Okay, previously called pneumocystis carinii. Now it is called as pneumocystis jirovecii infection. That is the commonest, organism causing pneumonia in HIV infected patients. That's what you should remember. Okay. Now comes the question. I have told you so many organisms. Okay, leave all that. Question is very simply asked. Which is the most common bacteria associated with pneumonia? That's a very simple looking question. What will be your answer? Or my question is overall most common organism. Please don't forget the overall most common one is Streptococcus pneumoniae. Please don't forget this. The overall most common organism causing pneumonia is Streptococcus pneumoniae. I think in pediatrics also you must have done the same thing only in children as well as in adults. Overall most common organism is Streptococcus pneumoniae. Please keep this in mind. Okay, fine. Now suppose I have a patient who is coming to the hospital with a diagnosis of pneumonia. See, pneumonia means what are findings they can have? They can have fever, they can have cough with sputum, and if you hospitate the patient, there will be crepitations. All those things will be present. Okay, I think these are all common features. Everybody remembers that. If you want, I can write it somewhere here. Common features. I'll just write it here itself. Okay, at the end of this. Okay, common features. These I think all of you should be able to remember. Common features will be fever, cough with sputum, or I will write wet cough, fast breathing. They'll have breathing difficulty, fast breathing, all those things. And what else? When you start hospitalating these patients, you will have crepitation, bubbling sounds. Okay, crepitations. These are all very common. Any type of pneumonia, you will have all these manifestations. Okay, you will have all these manifestations, right? You will have all these fever, red cough, fast breathing, crepitations, and all. Okay, right? Now, suppose this patient is admitted to the hospital. How I will know that it is a particular type of pneumonia? There are a few characteristics of each of these organisms which I'm going to list it down. I will start with the X-ray findings. Okay. Before I want to discuss, let me tell this because in the break time and all I was seeing, the students are asking for PDFs. This written PDF after the class and all. Okay, see, written PDF will not be shared first of all. Okay, right? It is for you to write it as I'm taking the classes. That's why I've shared the PDF workbook prior itself. Okay, right? So written PDF as such I will not be sharing, but these images, no, which I have put up. Okay, all these images which I have put up, extra images I'm talking about like these and all. These I will share, and of course the questions which I'm discussing also I will be sharing. But as such, the full PDF of written PDF like this will not be fully shared. This is for you to take it down as the class is progressing. Okay, please keep in mind. Fine. Okay, right. So let us start the discussion. The discussion. Next will be about something called characteristic X-ray pattern. This X-ray patterns will help me to distinguish few types of pneumonia. Okay. Now, any comments on the first X-ray? Anybody wants to comment on the first X-ray? This first X-ray here. This is the most common pattern. This is the most common pattern. Any comments? Okay, this is the most common pattern. What you can see is this one area is fully whitish in color. That white color represents nothing but the pus in that particular area. And you will see the pus as just a white color in the X-rays. And whenever radiologist sees this X-ray, they are not going to give it like a diagnosis or a name as pneumonia. What is the word they will use? They will use the word consolidation. And can you see in this particular picture what is happening? This one full lobe is consolidated. Can you see that this is the upper lobe? That full lobe, UL means upper lobe I'm mentioning, that one full lobe is consolidated. This is what is called lobar consolidation. This is the most common pattern which you encounter. Lobar consolidation. Okay, this is the most common pattern. Lobar consolidation. Okay, and lobar consolidation typically is noted in Streptococcus pneumoniae. It is typically noted in Streptococcus pneumoniae infections. Other organisms also can cause, but most commonly it is noted with streptococcal pneumonia. Please remember this. It is called lobar consolidation. Yes, Dr. Answer, that is correct. Okay, it is lobar pneumonia. Okay, fine. That clear? Okay, next one. Here, the second picture you don't see a lobar pattern of consolidation, right? But you are seeing some diffuse patches of consolidation. And you see that, I'll just try to mark it. See here. This is one area where you are seeing a consolidation. This is another area where you are seeing a consolidation. Third is this one. Fourth is somewhere on the top here. Okay, it's something like not one area showing the consolidation. It is multiple areas which are showing consolidation, but it is not just to only one lobe. Not one full lobe is affected. So I will not call this as lobar consolidation. I will call this as what? I will call this as patchy consolidation. Bilaterally, there is a patchy consolidation. Small patch like consolidation. Patchy consolidation. That's what you should remember. It is a characteristic of patchy consolidation. And in this patchy consolidation, you can also notice one more thing. What is that? Can you see something like small round areas like this? Small round areas here also. One more thing here also. Can you see something like small round, like a cavity is there, and it is filled with the air. That is why it is appearing black in color inside. The white color is the wall of the cavity. That black color is the air inside the cavity. What is the name of this? What is the name of this? The name of this is very simple. It is air inside the cavity. You call it as pneumatocele. You will call it as pneumatocele. You will call it as pneumatocele. Always remember the name meaning. Pneumo means air. Cele means something like cavity. So it's called pneumatocele. So it is called as a pneumatocele. Okay, fine. And this is caused by which organism? It is very classic law of Staphylococcus aureus. Please make a note. It's very classic law of Staph aureus infection. Staphylococcus aureus infection. That's what I'm trying to say. It's a very classic law of Staph aureus infection. Okay, fine. Now look at the third X-ray picture. Here I'm not even able to see a consolidation, correct? I'm not able to see a consolidation. So that is why this pattern is called as an atypical pattern. That's why it's called atypical pattern. All I can see is in both the lung field, there are some small dots like this. Something like this, small dots like this in both the lung fields. So it's not a typical pattern. That's what typical pattern should be like consolidation. Here I am not even able to see consolidation. That's why it's called atypical pattern. Any other name for this? It is also called as a interstitial pattern. It is also called as a interstitial pattern. It's also called interstitial pattern. Now, yes, it is also called as an interstitial pattern. Now, this interstitial pattern or the atypical pattern, the clue is in the name itself. What is that? Atypical organisms. Most commonly, what is that? Most commonly, it is caused by, in this atypical pattern is most commonly caused by the most common atypical organism. What is that? It is mycoplasma. It is mycoplasma. Okay. So what I'm trying to tell here is, based on the X-ray features, okay, we can get a clue as to what type of organism we may be encountering. Okay, so these three X-ray pictures should never be forgotten. Lobar consolidation, most common overall pattern, very classical of Strep pneumoniae. Patchy consolidation, pneumatocele, very classical of Staph aureus. Interstitial pattern, very classical of atypical organisms like mycoplasma. Okay, so please keep this in mind. This is important. Okay, now next thing what I'm going to put up is something which is very important. What is that? Every characteristic of some individual organisms. Okay, can you see some organisms I have selected? Streptococcus, Staphylococcus, Klebsiella. Next page you can see Mycoplasma, Legionella and all. I am going to tell you few important things which are like particular for that organisms. Okay, right? Why I want you to know about this is because this is the latest pattern question where they're asking not only pneumonia, asking some specific organism causing pneumonia by giving these characteristics. For example, pneumococci, already I told you what type of pneumonia does it cause? It causes lobar consolidation. That's what I have already put up, right? You can just quickly write it. It causes lobar consolidation. That is number one. Okay, it causes lobar consolidation. Number one. Number two, it also causes something like the sputum production, which is very typically called rusty sputum. Very important. It's very typically called as a rusty sputum. It's very typically called as a rusty sputum. Okay, make a note of this. It is very typically called rusty sputum. I see, very simple. Rusty is something like brownish red in color. What happens is that you don't need to write it. It is something like at the time when the patient is coughing and all, sometimes the blood can come out. Okay, and that blood, when the patient brings out the sputum, once the sputum comes out, the blood is also coming out. That blood will get oxidized, okay, because there is surrounding oxygen there, okay, right? That oxidization of the blood can result in that color becoming brownish red or rusty sputum. But this is something which is not usually observed in all the patient, but for the exam purpose, this is an important question. Rusty sputum is very characteristic of which pneumonia? It is Streptococcus pneumoniae, or it is also called pneumococci. Then what about Klebsiella? Okay, Klebsiella pneumoniae is something which is very important association with alcoholics. Don't forget this. It is associated with alcoholics. Okay. Second important point about Klebsiella pneumoniae is that think of the X-ray picture like this. It causes lobar consolidation. Think like This is the lobar consolidation it is going to cause. I'm writing it causes lobar consolidation. Okay, I'm writing like that. It causes lobar consolidation. What else also it can be associated with? What else also? Can you see, because of too much of pus in that area, this area is becoming like downwards displaced like this. Can any of you identify what is this area which I'm just highlighting in that red color? What is this area which I've just highlighted in this red color? Can you see that? This is the fissure. I think all of you know. This is the horizontal fissure which separates the upper lobe from the middle lobe of the lung. What is happening? So much of consolidation is occurring. It is lobar consolidation only, so that the fissure is actually bulging downwards. This is actually by the same name also called bulging fissure sign. Bulging fissure sign. Please make a note of this. It is called bulging fissure sign. This is very characteristic on the X-ray. Okay, very important. Bulging fissure sign on an X-ray is characteristic of which organism it is. This particular Klebsiella pneumoniae. Okay, right. This also causes lobar consolidation. Okay, that is the point. And one more thing about Klebsiella pneumoniae is that it can cause nematoceles on the X-ray. I told you, nematoceles are very characteristic of Staph aureus pneumonia. I have just told you like this, right? Before I have written nematocele, Staph aureus infection. But nematoceles can also be seen in Klebsiella pneumoniae. Don't forget this. One more important point about this particular Klebsiella pneumonia is that the sputum is of a different color. What is that color? It's called red currant jelly sputum. It's called as a red currant jelly sputum. Please make a note of this. It's called red currant jelly sputum. Okay. Why this red currant jelly sputum? It is because, again, blood mixed with the sputum only. But in addition to blood, there is some mucus also which is coming out, which is giving rise to that jelly type consistency of the sputum. So that's why it's called red currant jelly sputum. But this is an important question again for your exams. Okay. So red currant jelly sputum for Klebsiella pneumoniae, rusty sputum for Streptococcus pneumoniae are two very important questions. Okay, then we have Staph aureus. I've told you some features of Staph aureus. What is that? It causes patchy consolidation on the X-ray. And along with that, it can be associated with nematocele also. That's what I told you. Okay, and one more point about this Staph aureus infection is that it usually occurs following a viral infection. After a viral infection, it usually occurs. Typical example of that would be something like influenza, flu infection. So think like this: you have a patient during the season, he's having a flu. Okay, I think even just some time back, before only was a flu season in India, right? It is still going on also. So think like a patient had a flu infection, and following recovery from the flu infection, he had this pneumonia. What could be that organism? It is Staph aureus. So this is something which is important. It can occur following a viral infection also. I'm putting a star, which I feel is a very important thing to be noted. Okay, right. Now one more important problem about Staph aureus infection also. What is that? See, this is the X-ray which we are talking about. This is a nematocele, right? This is a nematocele. It is actually like a thin walled cavity. It's not a thick walled cavity. It's a very thin cavity. Why I'm saying like this is because it can easily rupture. Okay, it can easily rupture. When it is going to rupture, what is going to happen? The air is going to come out. And where is the air going to come out? Air is going to come out in the space surrounding the lungs. What is the space surrounding the lungs? It is nothing but, what is that? Pleural cavity. So the air can enter into the pleural cavity and can cause a problem. What is that? Air entering into the pleural cavity is called pneumothorax. So that is what you need to remember. This condition of Staph aureus is associated with, please write it very clearly, increased risk of pneumothorax. Increased risk of pneumothorax. And the reason for this increased risk of pneumothorax is nematocele, which is undergoing rupture. Don't forget this. Nematocele undergoing rupture is going to result in pneumothorax. Okay, don't forget this. This is important. Okay, right. So this will be the features or some characteristics of Staph aureus associated infection. Are you able to follow this? So strep pneumonia is over, Klebsiella pneumonia is over, and third thing is that Staph aureus associated pneumonia is also over. Now turn the pages, move on to the next page, which will be about mycoplasma. I told you already, mycoplasma is the best example of atypical pneumonia. You will learn in your micro classes that mycoplasma is called atypical organism because it doesn't even have a proper cell wall also. That's why it's called as an atypical organism. That is number one. Number two, anything else? Mycoplasma is something which is atypical because the pattern I have told you, it's not a typical pattern. It's an atypical interstitial pattern. That's why it's also called atypical pneumonia. And third important point about mycoplasma pneumonia is that the patients are otherwise healthy young patients. They are otherwise healthy young patients. That is the point. Something like adolescents like that. They're usually otherwise healthy young patients. Now, why I am saying like this? Because generally when we talk about pneumonia as a severe infection, we expect the patient to be sick looking, admitted in the wards and all. But this type of mycoplasma is something which occurs in otherwise healthy young patients. They're usually otherwise healthy and young patients. And in these patients, okay, they will present with cough, but it would be a dry cough, meaning they would not bring out sputum. Do you see in the previous things and all I was telling you, sputum is always present, like red currant jelly sputum, like this rusty sputum and all, but here there won't be any characteristic of the sputum. They will not bring out sputum also. It is more like a dry cough. And in this particular condition, signs means the things which we elicit on auscultation, examination of the patient and all, will be much, much more than the symptoms. Will be much, much more than the symptoms. This is also very atypical because we are generally expecting symptoms to be more than signs. But in this particular condition, signs are more than the symptoms. This is also something which is, this is also something which is atypical, correct? And it is something like this. What is that? The patient will come to you, not in the ward or in the emergency room. He will come to you in the OP only with fever, cough, something like that. He says, Doctor, I'm having fever and cough for 3 days, like that. That's all. He will be otherwise healthy looking. And the moment you put the speck in that patient, you will hear a lot of crepitations which are present. Something like crepitations are a sign of pneumonia, right? Lot of crepitation will be present. And you will be thinking how this patient is able to be so active and so healthy in spite of having a pneumonia. So that is why this type of pneumonia is also called as what? Walking pneumonia. That is why this mycoplasma pneumonia is also called walking pneumonia. Means the patient is walking around with pneumonia, meaning that it is otherwise not a very dangerous condition. That's what I'm trying to tell you. Clear? And only one more thing, it is not related to pneumonia per se, but can be given as clues in your exam. What is that? Association of this condition is with hemolysis. It is with hemolysis. They can cause, it can be associated with hemolysis. That is the important thing. And you are going to find out what is this cold agglutinin positivity means. It is purely a microbiology section, which you are going to find out. If your micro classes are over, you can look up in your notes if it would be already written. If it is not over, okay, you just try to find out what is the meaning of cold agglutinin positivity, which we very typically connect with mycoplasma infections. Okay, please have a look at it today itself. It won't take much of your time. It's a very simple thing only. Okay, right. Yes, Dr. Anjali, you're asking why pneumothorax is not seen in Klebsiella. See, it can be seen. It can be seen. But what I am saying is pneumothorax as a complication is very, very characteristic of Staphylococcus aureus, because the point about Staphylococcus aureus is that it's a very thin walled cavity. It can easily rupture. So that is why pneumothorax is more frequently seen with Staph aureus infection, and that is the point I want you to remember also. Okay, fine. So that's about mycoplasma. Last one was this year's exam topic. I think in your January exam, this question came: Legionella associated pneumonia. Some characteristic features. It is not something which you will see frequently, not at all. It occurs in small outbreaks. For example, in one particular hospital where the students are staying, okay, from one student to another student, it is spreading, something like that. Or it can occur in an office setting where from one employee of the hospital to another employee, it is spreading like that. So it's like a small group infection actually. And the source of this is found to be, any idea what is that? That is given in many of your clinical questions. Source of this Legionella infection. Any of you know about this? It is contaminated air conditioners, contaminated ACs. That is why we always say that in big areas and all, where AC should be serviced properly, because air conditioners or cooling towers and all, if they are not conditioned properly, if they are not serviced properly and all, it can predispose to this particular type of Legionella infection. Because Legionella is an organism which colonizes very, very moist areas like this AC, coolers, all those areas. If they are not serviced properly, it is bound to happen. Okay, so small hospital settings or small office settings, something like that, that is where it is usually being noted. And for you to remember in your exam, this is a condition which is also coming under which group? Typical or atypical group? It is also coming under atypical group. So you will have some extra manifestation, like in the form of diarrhea you can have. Also, they can have neurological manifestations. Like for example, the patient can have unusual confusions, all those things, okay? Confusions, something like not having a proper sensorium or even having headache also. Okay? All these things will be there. So these would be clues like outside the pneumonia which you can get in a patient with Legionella. And when you do the lab investigation, very, very important clue is that they have hyponatremia. Don't forget this. They have hyponatremia. This is something which is very, very important. Important clue is that they have hyponatremia. I'm not going into the details of why hyponatremia, but it is something like this. What happens? Legionella is associated with something called SIADH. I think all of you might have heard about this. If your endocrine sections are over, you may be able to understand what I'm talking about. syndrome of inappropriate antidiuretic hormone. What will antidiuretic hormone do? The antidiuretic hormone will retain lot of water from the kidneys. So it will not allow the water to be excreted by the kidney. Lot of water gets retained inside the body itself. Okay, lot of water gets retained inside the body itself. And whenever a lot of water gets retained inside the body, it will cause dilution of the sodium when you are drawing the blood sample. So this is what is the reason for hyponatremia. If you're not able to understand it very, very clearly, it is okay. It is not a problem now. You just remember hyponatremia. That's enough. Once your the sessions are over, like this physiology or this endocrine sessions are over, you'll be able to understand what I'm talking about. It is an association with ESI-ADH, you get hyponatremia, and this is one of the very, very important clues. Okay, I think this time in the exam, January exam, there were two clues which were given. One was regarding the contaminated ACs, which was given. Second clue which was given in the question was regarding hyponatremia in a patient with pneumonia. In this setting, you have to think about Legionella infection. Are you able to follow this, right? So please keep in mind, this is possible question which can be repeated again also. So these are some of the characteristic features of different organisms which are associated with pneumonia. I feel this particular table is something which is very, very important as clues. Any of this can be picked up in your exam along with the clinical picture of pneumonia, and they can ask you which organism you are dealing with. So two type of question. One is the ones which I have written, execute which condition does it occur, what are the signs, what are the additional things and all which can be asked. Second type of question which I feel are important in exam is something like this, X-ray based question. They can put out the X-ray and can directly ask you what is the condition you are dealing with. So both this type of question, please be prepared for. Clear? Okay. Now finally, okay, yes, this one, HIV and organism causing pneumonia. There was one more question in this particular January exam. There are actually two questions in January exam. One was Legionella related question in pneumonia. Second question related to pneumonia was HIV infection in the organism. I told you what is the commonest organism. I told you pneumocystis infection. But that pneumocystis infection is something which will develop with the cell count, CD4 count of less than 200. That is the time when actually pneumocystis infection will develop. Pneumocystis infection will develop less than 200 cell count. Any other organism also can develop if it is like this histoplasma also. But don't get confused. I think you can stick to the important one. If they ask you a single organism, which is common in a HIV infection with a CD4 count of less than 200, it is pneumocystis infection. I think that you can remember it. What was your exam question this time? The question was very clearly mentioning this is a HIV positive patient, but he had CD4 count of less than 50 per microliter. Less than 50 per microliter. In this setting, what would be the commonest organism? Any idea? Any idea? Anybody wants to comment? In this setting, what is the commonest organism? HIV infection and the cell count is less than 50. Any comments? Waiting for any answer. Okay. See, it is atypical mycobacteria. Okay. Atypical mycobacteria. Atypical mycobacteria. Sorry, mycobacteria. I think some of the app, the message is not getting delivered properly. Very good, very good. Very good, doctors. Okay, right? Atypical mycobacteria. Very correct. One more is what many of you were saying. Okay, CMV also. I agree to that. Cytomegalovirus also is important. That is fine. And one more is atypical mycobacteria in the form of MAI. What is that? Mycobacterium avium intercellular. Okay, I think that was a question which came in this January exam regarding this. Okay, right? So CMV can be there. That is okay. CMV pneumonia also can be there. That is true. But among the bacteria, it is this one. Okay. This is Mycobacterium avium intercellular. Okay, fine, good. Many of you were able to answer that. And more, less than 500. Okay, less than 500. Yeah, I will see. Okay, less than 500. It is, what is that? Mycobacterium tuberculosis. MTB. Mycobacterium tuberculosis. Okay, right? So please make a note of this. These are some of the infections which are commonly causing pneumonia in children with HIV. See, some of you are saying the other things and all. Like Kaposi sarcoma. Kaposi sarcoma is not pneumonia, right? It can occur, that is fine, but it's not a pneumonia, right? We are talking about HIV and organisms causing pneumonia. You can see that very clearly, HIV and organisms causing pneumonia. That is where all these things should come into account, okay? I feel this particular table itself is very, very important for your exam. Keep a note of that and please keep following that. That is something which can be repeated again in high probability in your exams, okay? So don't forget this, fine. Okay, so this is all about the pneumonia part. Okay, right. Now, what are the classical findings in pneumonia? I have already told you the patient can have fever, cough, and all. Now, if you start examining the patient, what are the findings you can get? Very simple. Percussion. I think all of you might be knowing about this. What you do? is something like this. You keep your fingers like this over the patient's chest, and then with your other finger, this middle finger like that, you have to tap over the chest like this. This is what is called percussion. Now, generally, you get a note like this. I think all of you can appreciate that. Now, in case of pneumonia, what type of percussion note you will get? It is something like a lot of pus is there inside the lungs, right? So the note, see, normal note is called normal percussion note. Sorry, normal percussion note is called as a resonant note. Okay, something like what you hear whenever you tap with your fingers over the chest like this. Okay, that is what is a normal percussion note. But here, what is happening? A lot of pus is getting filled up, right? When the pus is getting filled up, you will not get a normal percussion note. You will get a dull note. Very important. You will get a dull note. This is very, very important. You will get a dull note. Are you able to follow this? It is a dull percussion note. That is what you have to remember. Fine. That is number one. Number two, breath sounds. Do you know what is the normal quality of the breath sound? When you auscultate with your stethoscope, what is the normal quality of the breath sound you call it? It is called vesicular breath sounds. It's called vesicular sound. It is called as a vesicular breath sound. Now, what happens in case of pneumonia? Can anybody tell me that? I'm not talking about all pneumonias. I'm talking about lobar consolidation cases. Any idea? Please remember, pus, that is what we're talking about in pneumonia, is a better conductor of the air. That is the point to be noted. So what type of sound you will get is something like a little harsh sound you will get. That type of harsh sound is what we call it as a bronchial breath sound. The quality of the breath sound is called as a little harsh breath sound. Harsh means what? It's a better conductor of the air. What is that? The pus is like a better conductor of the air. So you will get a little louder sound compared to normal sound. So it is called as a bronchial breath sound. It's a very characteristic type of sound which you get in this. Others is something like vocal fremitus. Vocal fremitus. Any of you know what is the meaning of vocal fremitus? You keep the steth over the chest area and ask the patient to just say something. Normally, you will hear a sound like that, which will be very distorted, which will be very, like, not a, see, suppose I am saying A, B, C, D like that. And when I keep the step over that area, I will not hear the same A, B, C, D in my ears when I keep it through the step. Because what happens, the sounds as they get produced, they will be something called dampened by the lungs. Okay, so you will not hear exactly like A, B, C, D. Something like little differently you will hear. Okay, but what is happening in case of lobar consolidation? A lot of pus is filling in that area, and I told you pus will conduct the sounds better. So what happens? If I say ABCD, I will clearly hear the ABCD only. This is what we call it as increased vocal fremitus. Vocal fremitus is increased. Very, very simple reason that the sounds are better transmitted with the pus inside the lung. So that is why vocal fremitus will be increased. Okay. And what you can do is one more thing. You ask the patient to whisper something. Whispering means like in a low voice, you ask him to whisper something. And you keep the step. Will you hear that whispering sound? What the patient is saying, will you able to hear properly? No, because normal lung will dampen all the sounds. Whereas in case of consolidation, I told you pus is a better conductor of sound. So whatever the patient whispers also, you can very easily hear when you keep the step in that area. This is what is called whispering. This is what is called whispering pettorlogi. Okay. Okay. This is called as whispering pettorlogi. Please make a note of this. Means when the patient is whispering and you hear it with the step, you can very easily hear it or very clearly hear it. The reason why you're able to hear it very clearly is because the pus is a better conductor of the sound. That's all. Are you able to follow this, right? And of course, what is the type of additional sounds you will hear? I told you crackles or crepitations will be here. Crackles or crepitations. These are the characteristic set of findings which you will encounter in a patient with lobar consolidation. Please make a note of all these. These are all very important clinical examination findings. Little later, I will do a comparison of all these clinical findings when I do the other topics also. At the time, again, I will come back to this findings only. Okay, I hope you're able to follow this. These are the clinical examination findings which you can get. Grunting can be heard mostly in children only, doctor, not for adults. Okay, it's mostly in young children, that 2 neonates only you get the grunting, not here. Usually, you don't get grunting here. Okay, fine. Okay, right. So that is about some of the important clinical examination findings which will be present in the patient with lobar consolidation. Now, coming to the last part, what is the last part? Last part will be about management. Suppose you have a patient with pneumonia. How are you going to manage it? The commonest one, it is based on scoring systems. Okay, it is based on scoring system. We have 2 scoring systems, as you can see. Number 1 and the commonly used one is a curve 65 score, which is what we are going to see in detail. Number 2 is a new scoring system. You don't need to know it fully, just the name only. It's called PSI. Any idea what is this PSI called? Pneumonia Severity Index. It's called Pneumonia Severity Index. Okay, this pneumonia severity index is for prognosis. Prognosis means for the outcome of the patient. Okay, it is for deciding the outcome of the patient. Okay, it is for deciding the outcome of the patient called pneumonia severity index. It is for prognosis purpose only, not for diagnosis. But that is more for a research level or a little advanced level. You don't need to know this PSI score in detail. You can just know the name alone and leave it there. What you should be knowing in detail is curve 65 scoring only, because this curve 65 score is the one which will help in management of a patient with pneumonia. It will help in the management of a patient with pneumonia. There are different versions of this curve 65 score. What is the latest version is what I'm going to discuss about. Okay. Any of you know what is this curve in this curve 65 score stand for? Any idea? Curve in this curve 65 score? See, everything is for one parameter, something like that. C is for, and if you know that, C is for what? Confusion. Okay. Patients having some mental disturbance or confusion. That is what is called C. C is for presence of confusion. What is that U for? U for urea levels, serum urea levels more than 20 milligrams per deciliter. In terms of millimoles per liter, more than 7 millimoles per liter. But what we are using in India commonly is milligram per deciliter. So I will stick to that, more than 20 milligrams per deciliter. R is for the respiratory rate. R is for the respiratory rate. Obviously, what will happen to the respiratory rate? Respiratory rate will be increased to more than 30 per minute. B is for blood pressure. What is that blood pressure we are talking about? It is a decreased blood pressure. Decrease in the blood pressure, which is defined by systolic blood pressure less than 90 millimeters of mercury, or diastolic blood pressure less than 30 millimeters of mercury. That is what we are talking about as the blood pressure related in case of this particular thing. Okay, blood pressure related. And 65, any idea what does 65 stand for? Age. Okay, it is the age of the patient. It is the age of the patient. Age more than 65 years. These are the things which we will talk about, okay, in the curve 65 score. Okay, please be very, very clear about this. Everything stands for one of the everything stands for one of the important things. Everything stands for one important parameter. And each of these parameters, how are you going to give the scoring? If it is present, it is given one score. Okay, if it is present, you give a score of 1 for each of these parameters. If it is absent, it's given a score of 0. For example, confusion present, you give a score of 1 for that. Confusion absent, you give no score for that. So for that, every parameter you have to take into account. You have to check the respiratory rate, you have to check the blood pressure, you have to check the serum urea levels, and you also have to check the age of the patient. For everywhere, you give 1 if it is present and 0 if it is absent. Okay, so think like this. Age, what is that? Age, I told you, more than 65 years. So 70-year-old patient, we will give 1 score for that age 65. If it is just a 40-year patient, we will not give any score for that. So something like that. So every parameter, you will give a score of 0 or 1. Finally, you will add all the scores. And based on the final score, based on the final curve score, in the next page you can see, based on the final curve score, you have to manage these patients. Okay. So how it is classified? Very simple. Yes, any idea? If it is 0 to 1, it is called mild pneumonia. That's all. Mild pneumonia. Where do you think the patient can be managed? In the home itself. You will send the patient home. Very, very simple. That's all. It's called mild pneumonia. 2 means it is moderate pneumonia. Moderate pneumonia. In moderate pneumonia, the patient has to be kept in the hospital. It should be inpatient. But where can he be kept? He can be kept in the ward itself. That is the point. He can be kept in the ward. What about 3 or more than 3, like 4, 5 and all? It means it is a severe pneumonia. Obviously, severe pneumonia patient again has to be kept as an inpatient only. But where he should be admitted? He should be admitted in the ICU setting. So please make a note of it. It's in the ICU setting. So mild means home management, moderate means ward management inpatient, and severe means it should be ICU management. That's what you need to remember. Okay, it should be ICU management. Are you able to follow this? Okay, right. Now, next thing, what you have to remember is the antibiotics. Okay, obviously pneumonia is commonly caused by bacteria, so you have to decide on the antibiotics. Okay, now this is where you have to be a little careful. Just a minute, because if you go by different textbooks, so many versions are given. Okay, right? Davidson gives one thing, Harrison gives some other thing. Even our Indian textbooks also give it slightly differently. So what I am going to do is I am going to put up what we follow in the Indian scenario, and that is what you need to take as the final answer. See, home management means obviously that antibiotic, but what type of antibiotic? It would be oral antibiotics. Any idea which oral antibiotic we can give? Which oral antibiotic we can give? We can give common one. What is that? Amoxicillin. We give commonly, yes, amoxicillin. But nowadays, so many resistance has been reported. So now they are saying even amoxiclav. I think all of you know this. Amoxiclav means combination of amoxicillin and clavilone or clavulanic acid, right? You can give amoxicillin or amoxicillin clavulanic acid. Now, if the patient, very important point, if the patient is penicillin allergic, if the patient is penicillin allergy, if it's a penicillin allergy patient, what do you have to give? You can give something like a macrolide. That is what is azithromycin, clarithromycin, like that. I will write one example. You can give azithromycin. Okay, you can give azithromycin, or you can go for the doxycycline. Please see, this is what the guidelines are saying very clearly. Start with the penicillin group of drug like amoxicillin or amoxicillin clavulanic acid. If the patient is allergic to penicillin, then you can go for azithromycin or doxycycline. This is what the latest guidelines say, and that is what we are following also. I hope you can follow this, right? So this is what oral, which can be done from the home setup itself. Suppose the patient is having moderate pneumonia according to the SCORB score, which is score of 2. Then obviously I told you we have to put him in inpatient, right? But in the ward setup, it's not a very severe condition, so you can put him in the ward. Now in the ward, what is the drug you are going to give? Again, amoxiclav. Along with that, you can give an this macrolide group of antibiotic, typically recommended in the hospital setting is a clarithromycin. So things like this. You have to use a combination. So please make a note of this. We have to use a combination, right? Amoxicillin clavulanic acid plus clarithromycin. Only thing is, again, if the patient is penicillin allergy, if the patient is having penicillin allergy, if the patient is penicillin allergy positive, instead of amoxicillin clavulanic acid, what you can do? You can use a doxycycline or levofloxacin. Doxycycline or levofloxacin. That is what is the recommendation. If the patient is allergic to penicillin, instead of amoxiclav, you can give doxycycline or levofloxacin. You able to follow this, right? Or levofloxacin. Then the last one. What is the last one? The last one, you are putting the patient in as an ICU patient. So obviously, when the patient is put in ICU, you have to give a better drug. So here I will not use penicillin. I will straight away go to the cephalosporin route. So what is the drug I am going to use in the ICU setting? I will use a combination of ceftriaxone. Okay, I will use a combination of ceftriaxone. That is a broad spectrum. I can use that. Along with the ceftriaxone, I have to use clarithromycin or levofloxacin. Please make a note of it. Or levofloxacin. Or levoflox. That is the point you need to remember. Or levoflox. Are you able to follow this? Ceftriaxone plus clarithromycin or levofloxacin. Are you able to follow this? Okay, right? So this is something according to the situation, according to what type of management you have to choose the antibiotic. Of course, I do agree that it may appear to be slightly tricky now, but please go through this list only because that is where your questions are asked from. Because based on the curve 65 score only, we decide on the management. I think the usual question which is asked in the exam is the patient is coming as an outpatient. Which drug you will, the patient is going to be managed as an outpatient, which drug you will use? That is what is the usual question which is asked in your exams. Only one thing I wanted to add is, suppose you are working in a hospital where there's a high incidence of MRSA, that is methicillin resistant staph aureus. If you are suspecting MRSA due to the hospital setting which you are working in, what you will also add, which drug you will add without fail to the treatment? MRSA, which drug should be added? I think most of you should be knowing this. You should add vancomycin. You should add vancomycin, correct? You should add vancomycin. So these are the principles of treatment whenever you have a patient with pneumonia. I hope you're able to follow this. Is that clear, doctors? Are you able to follow this? Good. Okay, right. So that is all about pneumonia management, which you should remember for a patient. Okay, right? See, pneumonia is a topic. Again, I'm telling you, it is very, very important for the exam. So many questions have been asked in the past, and even this year, this January exam also, we had 2 questions from the pneumonia section. One was about the Legionella pneumonia, where they had mentioned like contaminated AC, hyponatremia, and all was given. That was one question. Second question which was asked in the exam was related to this one. What was that? Regarding the HIV infection and the pneumonia. What is the commonest organism? So both these, again, I feel are important for the exam. So please make a note of this. Okay, clear. So that's about our discussion of pneumonia in children. I have covered all the aspects, starting from the commonest organisms along with the definition of pneumonia. Then I told you about clinical examination findings in pneumonia. Third, I told you about X-ray findings in pneumonia. And fourth was regarding the management aspect of pneumonia. In the management aspect, don't forget about curve 65 scoring. That's what I can tell you. That's very, very important for the exams. Okay, fine. That is about this particular condition. Next, we move to a condition where fluid accumulates inside the lungs, called as a pleural effusion. Okay, this I think is a common topic again, pleural effusion topic. I will tell you what type of questions are expected as and when we keep discussing. Okay, so any comments about this pleural effusion? Okay, so I'm waiting for an answer. What is the normal amount of fluid inside the pleural cavity? Pleura is something which covers our lungs, right? And there are two types of pleura, as you must be knowing. What are the two types of pleura? One is the visceral pleura, another one is called as the parietal pleura, correct? So we have visceral pleura and the parietal pleura. You tell me one thing, which pleura is pain sensitive structure? Which pleura is a pain sensitive structure? Is it visceral pleura or parietal pleura? Okay, P for P, you remember, parietal pleura is actually the pain sensitive structure. Okay, right. Now let us look at some of the important points regarding this pleural effusion. Okay, one more question I asked, what is that? What is the normal amount of pleural fluid? See, many books will give differently. I will go by a common range. Okay, any of you can answer this? For the normal amount, very good, correct. It is around 10 to 30 ml. Yeah, that is what textbooks will differ. Some will say 10 to 20, 5 to 15, like that. That's okay. But general range is around 10 to 30 ml is the amount of normal fluid levels. Okay, pleural fluid levels. Anything more than this is what we call it as a effusion. Okay. Now you answer one thing. Suppose the pleural fluid is 50 ml. Do you think patient will have any problems? Or when do you think clinically the pleural fluid becomes evident? When do you think at what level clinically the patient will experience some problems? The patient will experience problem whenever the pleural fluid level goes to more than 300 ml. More than 300 ml, the clinical features will become evident. That is also a point we need to remember. So whenever in a question, think like a clinical scenario question, they are putting up some features. I'm going to tell you the features of this particular pleural effusion. But what I want you to remember is whenever a patient, okay, is presenting with some features of pleural effusion, usually remember that the amount of fluid should be more than 300 ml. That is what you need to remember. Okay, fine. Now, what all features can a patient present with? What all features can a patient present with? Normal volume, I have already mentioned, is 10 to 30 ml. What all features they can present with? They can present with something like heaviness in the chest. See, there's a lot of fluid in the lungs, right? Surrounding the lungs. So they will complain of heaviness. They will complain of heaviness present, will be present. They will say that I am feeling some heaviness in my chest. Like that, they can tell. They can also have breathing difficulty. They can have this breathing difficulty. And very, very rarely, when the pleura is inflamed, okay, because inflammatory conditions can also cause pleural fluid, like pleuritis and all. They can have pain present. They can have pain which is present, okay. Pain present means in the lateral chest they will have the pain, not in the central part of the chest like angina and all. No, they will have in the sides of the chest. So it will be in the lateral chest they will have pain, and this pain will be worse on inspiration, as well as worse with coughing. This is important. This is something characteristic of pleural pain. Please make a note of it. Pleural pain is not in the center part of the chest. It will be in the sides of the chest only, like in the sides like this. And this pain will be worse on inspiration. You think like this. What is happening on inspiration or coughing? Whenever we are coughing or having an inspiration, what is happening? Our lung is expanding. Our lung is expanding means the pleural area is getting compromised. When the pleural area is getting compromised, the patient will feel the pain. That is what I am trying to tell you. Okay. So this is what you need to remember. Pain will be worse when the patient is coughing or at the time of inspiration. We're able to follow this. Okay. Right. Okay, so these are the features which will be present, and please don't forget when the features are going to be present, at least how much of fluid is present already. 300 ml of fluid is present already, then only the patient will present with clinical features. Okay, fine. Okay, now let us see what are the conditions which can cause pleural fluid effusions. Okay, this is where you have to learn the concept of transudate and exudate. Any of you know what is the concept of this transudate and exudate? Any idea? Any of you have any idea? Transudate is something basically which is an imbalance between the pressures. Which is an imbalance between the pressures. It's a condition of imbalance between the pressures. I think you all must be knowing about this. In pleura, there is a lot of pleural capillaries. Okay, in pleura there is a lot of pleural capillaries. I think all of you must be knowing that. Okay, and in every blood vessel in the body, there are actually two types of pressure. One is called as the oncotic pressure, another one is called as the hydrostatic pressure, which I think most of you must be knowing it. Okay, and whenever there's an imbalance between these two pressures, what will happen is that there would be fluid leakage. Okay, imbalance between these two pressures will result in fluid leakage, and that is what gives rise to the transudate type of pleural effusion. Okay, so pleural fluid leakage means I'm talking about fluid in the pleural cavity, and that is what is called as a transudate. So transudate basically, remember, imbalance between the two pressures. So what could be that imbalance? It could either be an increase in the hydrostatic pressure either be an increase in the hydrostatic pressure, or it would be something like decrease in the on-contact pressure. Decrease in the on-contact pressure. These are all physiology concepts, doctors, okay, right? Increase hydrostatic or decrease on-contact pressure. Any idea which condition leads to increased hydrostatic pressure? Increased hydrostatic pressure is seen in all conditions like failure, like heart failure, you can get increased hydrostatic pressure. Renal failure, you can get increased hydrostatic pressure. Liver failure also, you can get increased hydrostatic pressure. So I'm going to write like this, all types of failure. Heart failure, liver failure, renal failure. In all types of failure, you get increased hydrostatic pressure. I hope you're able to follow this. Okay, you get increased hydrostatic pressure in all types of failure. Now, on-contact pressure. Any comments on this on-contact pressure? On-contact pressure is something related to the plasma proteins like albumin. Think like this. Albumins contribute to on-contact pressure. So whenever there is fall in the albumin, there would be fall in the on-contact pressure also, and that would result in edema. Any idea? Can you think of any condition? Typically, you get this albumin deficiency, and you can get this edema or decreased on-contact pressure and all. Very classical condition is something involving the kidney. I have given you the clues. You can tell me any answer. Which condition in the kidney? Yes, it is nephrotic syndrome. It is nephrotic syndrome. Very classical example. Nephrotic syndrome. So please make a note of this. In all these conditions, you get transidative type of pleural effusion. In all these conditions, you get transidative type of pleural effusion. Basically, it's an imbalance between the hydrostatic pressure and the on-contact pressure. I hope you're able to follow this, everyone. Fine. Okay. So this will be transidative type of pleural effusion. And one more important clue in the X-ray would be, or findings would be, usually it's a bilateral effusion. Please don't forget this. It is usually bilateral. Whereas on the other hand, exudate is usually due to, exudate usually manifests as unilateral effusion. Exudate is usually a unilateral effusion. Any comments? Anybody wants to say what condition can cause exudative pleural effusion? Exudative pleural effusion is a condition which is characterized by increase in the leakage from the capillaries, increase in the leakage from the pleural capillaries. So you think of like this, there is some damage to the pleural capillaries, that is why the fluid starts leaking out from them. You think like this, okay, right? Something which is damaging the capillaries can cause leakage of the fluid from the capillaries. Here there is no pressure problem, pressure and all is okay only, but something has damaged the capillaries, resulting in leakage of the fluid out of the capillaries. What could be that something? What could be that something? Three things should come to your mind whenever I talk about exudative pleural effusion. One, infection. Two, inflammation, inflammatory condition. Three, malignancy related condition. These are the three things which should come to mind whenever we talk about exudative pleural effusion. Three things, don't forget this. Infection, inflammation, and malignancy. Three things which should always come to your mind. Okay. So what all it could be? Infection, of course. One thing which will always be remembered is the pneumonia. Pneumonia with the effusion itself is a special topic which I will come to little later. Please write now pneumonia. I will come to the pneumonia associated effusion in a short while. Number one. Number two, very important in our country, will be about tuberculosis. Tuberculosis is a very separate type of infection which is independently associated with this effusion. So this is tuberculosis. Then I told you after infection, it is an inflammation. Typical example would be something like connective tissue disorders. The example would be something like rheumatoid arthritis. Typical inflammatory condition, rheumatoid arthritis. Very classical. Okay, even conditions like SLE, all those things, they are coming under inflammatory condition. Third, I told you, is the malignancy. Okay, in malignancies, any idea which one in the malignancies? Malignancies, two important malignancies which you should remember. One is the lung cancer, another one is the breast cancer. Please don't forget this. Okay, these are two important malignancies which can be associated with this thing. Okay, and in the inflammatory condition, I want you to remember one special category. What was that? It was one of the pneumoconiosis. I told you, one of the pneumoconiosis which can be associated with pleural effusion. What is the pneumoconiosis which is associated with pleural effusion? Can anybody recollect that? Can anybody recollect that? What is that pneumoconiosis which is associated with pleural effusion? Very good. It is asbestosis. Do you remember in asbestosis, I told you the earliest finding of asbestosis itself is asbestosis, benign asbestosis related pleural effusion. Do you remember the short form also I used this? BAP. What is that? Benign asbestosis associated pleural condition. I hope you can follow this. Okay. So these are typical examples of pleural effusions associated with the, yes, Dr. Shil, correct. Okay, right. These are the typical examples of exudative pleural effusion. I hope you can follow this. See, from this itself, I have seen a lot of questions. Okay, from the types of pleural effusion itself, I have seen questions. All of the following are associated with exudative pleural effusion, except like that. I have seen questions in the past, so please make sure you know about this. Okay, clear everyone? Okay. Now there is only one type where you can get both exudate as well as transudate. There is one condition where you can get both exudate as well as transudate type of pleural effusion. This itself is a special question. Till now, this question has not been asked for the exam. But I feel that going by the present pattern of question, this can be asked in the upcoming exams also. Any name, any condition where you can tell me like both exudate as well as transudate pleural effusion. We have yet to discuss about that condition, which will be the next condition I'll be discussing after this. What is that? It is pulmonary embolism. Pulmonary embolism or pulmonary infarction. That condition can have both exudate as well as transudate. Suppose I put up a question. I put up like a scenario. You are encountering a question where they have asked all are exudate, transudate, except like that. And you have to make a decision. Pulmonary embolism is also given the option. I told you pulmonary embolism can be both exudate and transudate. But if you want to choose only one thing, which is pulmonary embolism more characteristically associated with, you remember the clue is in the name itself. What is the embolism? It is more of exudate more than the transudate. That is what you need to remember. It is more of exudate rather than a transudate. So please make a note of it. E for E. Pulmonary embolism is more of exudate. That's what you need to remember. This is a question which is not yet asked till now, but I feel that it may be asked definitely in the upcoming exams. Okay, right? Fine. So please make a note of this pulmonary embolism, E for exudate and embolism, like that. So these are the causes of this particular effusion, pleural effusion, which I want you to remember. Next is, suppose I have a patient with pleural effusion. I am thinking probably this is transudate only, but still I am in a dilemma whether this is transudate or an exudate. What is the best way to differentiate between the two conditions? Very simple. You have to take out the pleural fluid itself and then analyze it. So that is what is this one, pleural fluid analysis. This is also, I'm putting a lot of stars for this because this by itself is a very, very important MCQ topic. I have seen questions like this. They give you the set of findings and they ask you. They don't give you about any clinical history of the patient. They will just straight away start the question like, this is a patient who is having pleural effusion and the following findings are noted. What would be the type of pleural effusion? Like that also questions have come. So that is why you should know about the differences between the two conditions. Any idea? Any idea? First is pleural fluid protein and serum protein. See, first I will tell you for exudate because that is easy for me to explain. Okay, easy for me to explain. What is exudate? I told you basically it's an increased leakage situation, right? It's an increased leakage from the capillary. So what is getting leaked? Fluid is getting leaked. That is why you are getting effusion. And in that fluid, lot of LDH will be there and lot of protein also will be leaked from that fluid. Okay. So what will happen? The amount of pleural fluid protein will be increased in case of exudative pleural effusion. What do? We will compare this exudative pleural effusion. Sorry, we will compare this pleural fluid protein with the serum protein. Normally, the amount of pleural fluid protein is less than half of the serum protein. Or in other words, normally what I am saying, it is 50% or less than 50% of serum protein. For example, I am saying serum protein level is 4 grams. What should be the pleural fluid protein? Normally, it should be less than 2 grams or it is less than 50%. But in case of exudate, I told you a lot of protein will be there in the pleural fluid, right? So what will happen? The level will be more than 0.5 or more than 50%. For example, the serum protein is 4. The pleural fluid protein will be more than 2. That's all. Very simple. The pleural fluid protein will be more than 2. Are you able to follow what I am trying to say? Pleural fluid protein will be more than 2. That is what it is. Okay, right. This is comparison between protein in the pleural fluid and the serum. What I'm trying to say, so much of protein will be there in an exudate, so the ratio also will increase. That's all. Second thing is about LDH. What about LDH? I told you there is also a lot of LDH in an exudative pleural fluid. So again, what will happen? The ratio between pleural fluid LDH and serum fluid LDH will always be increased. Normally, it is like 60% or 0.6. Here it will be more than 0.6. More than 60%. That's what I'm trying to tell you. More than 0.6. Then third is pleural fluid LDH in comparison with serum LDH only, but here we are not expressing in 0.6 or percentages at all. It is like 1/3, 2/3, 3/3, or completely like that. Okay. So here it will be more than 2/3 of the pleural fluid. For example, serum LDH. Serum LDH is 300 milligrams. Think like this. What will happen in an exudate? It will be more than 2/3 of that. What is the meaning? It will be more than 200. Pleural fluid LDH will be more than 200 in case of exudate. I hope you are able to follow this. Okay, clear? So what are we trying to do is we are trying to compare the pleural fluid LDH, pleural fluid protein with the serum protein and serum LDH. That is what I'm trying to tell you. And please remember, everything will be opposite for transudate. So what will I write for transudate? Level of pleural fluid protein to serum protein will be less than 0.5. level of pleural fluid LDH compared to serum LDH will be less than 0.6. And third one, pleural fluid LDH in comparison to serum LDH will be less than 2/3 the limit of serum LDH. That's all. So everything will be opposite. Now here comes the criteria called as Light's criteria. This is something which is very important. What does the Light's criteria say? If you want to diagnose an exudative pleural effusion, out of these three things, any one itself is positive, either the elevated LDH or elevated protein like that, any one of that is positive, then it is called exudative pleural fluid effusion or exudative pleural effusion. And what about transudate? Transudate, if you want to call a condition to be transudate, all three of that should be present. All three should be present. Okay, that is what you need to remember. Okay, so for diagnosing an exudative pleural effusion, it is easy because any one criteria satisfied, you will call it. That's all. It's like criteria, it is exudative pleural effusion. But transudate, all three should be in the normal range. Then only you will call it as transudative pleural effusion. So I hope it is clear till this point of time. Please remember in your exams, this has been asked very frequently. How do you differentiate between transudative and exudative pleural fluid by pleural fluid analysis? Okay, this is important. Okay, then something called low glucose in the pleural fluid. By definition, it is something levels less than 60 milligram per deciliter. Levels less than 60 milligram per deciliter. And low glucose in the pleural fluid are sign of two important things basically for your exam. One is malignancy, almost like exudative only. It is a sign of inflammation, and also it can be seen in infections. So whatever I have told for exudative pleural effusion, everything will apply: malignancy, inflammation, and infection. So you can just remember low glucose is also a feature of exudative pleural effusion. Like that also you can easily remember. Okay, so this is how we will differentiate between this transudative and exudative pleural effusion. And one of the important causes of pleural effusion in Indian population is TB associated pleural effusion. Okay, TB associated pleural effusion. TB is what type of pleural effusion? Of course, TB is infection. All infection will be related to exudative pleural effusion. Here, when you analyze the fluid, you will always get findings of exudative pleural effusion. But the question is not like that. The question is, which is the best investigation for TB pleural effusion? So think like this. I give you options, not options. Okay, you can just tell me directly itself, which is the best investigation for detecting TB associated pleural effusion. See, what is the common testing we do for tuberculosis? Some of you can tell me. What is the common test we do for tuberculosis? In area, what is the common test we do for tuberculosis? To diagnose it. Any of you, any test you know of tuberculosis? See, we do something like this. Zee-Nielsen staining. We will do something like PCR testing, called as a CB-NAT test. Yes, of course, we do the X-ray. All those things we do. But do you think all of them can be diagnostic of this particular TB-associated pleural effusion? Not at all, because as far as pleural effusion with tuberculosis is concerned, the positivity rate is very low. It is only 30%, 40% if you do all these investigations. So now if they ask you the question, which is the best investigation? Your answer should be pleural biopsy. Very, very important. You have to take the biopsy from the pleura itself, and that specimen has to be sent for culture. Please make a note of this. This is something which is very important. Pleural fluid biopsy plus culture will be the best investigation for TB associated pleural effusion. That is what Dr. Ansar, you are saying as NAT and all. NAT is correct, that's what I'm saying. But for TB pleural effusion, NAT is only 30% or 40% positive. Same thing for NAT2 also. It is positive, but very, very less chance. Okay. Same goes for X-ray also. Okay, right. So all these tests you can do. I'm not denying that. But if the question is asking best investigation, always go for pleural biopsy as the answer. That is what I want you to remember, because in your options, CB-NAT will be given, X-ray will be given, all these things will be given. But please note it, the best result will be with pleural biopsy. That's what I wanted to emphasize much. Okay. Fine. Finally, we come to the X-ray aspects. I think these are all radiology questions which can be definitely asked in your exams. Is the radiology section over? Okay, right. First, I will tell you about the X-ray features. Okay, see these two X-rays you can see. One is the PA view, another one is lateral decubitus view. The common one which we do in the wards is with the PA view. But please remember, if you want to see any finding of fluid on an X-ray, minimum amount of fluid that should be present. Only then you will see the finding. Minimum how much? Minimum is at least 300 ml. Some books say even 200 ml also, but the standard one is minimum 300 ml of fluid should be present for you to see the findings on an X-ray. Don't forget, this minimum 300 ml of fluid is a fluid above which you can have clinical features of pleural effusion also. So I hope you can follow that, right? So minimum 300 ml should be present. And what are you seeing as evidence of fluid? The fluid will appear white in color. I think all of you should be knowing this. Fluid will appear white in color. So what is the evidence of fluid you are seeing? you are seeing those evidences here. Somewhere here, you are seeing that evidence. Somewhere here also, you are seeing that evidence. What is it? It is white in color. Sorry for that. Yeah, it is white in color. That is fine. But what you are noticing is these areas are not appearing prominent. Anybody can comment on these areas which I am now marking now. What is this areas? See, normally you should have a markings like this, correct? You should have markings like this. Anybody wants to comment on that? Like same thing here also. You will have a marking very prominently like this, but it is not prominent. What is this one? Any comments? Anybody wants to comment on this? What is this? It is called as the angle between the heart and the lungs or the diaphragm. What do you call that? It's called cardiophrenic angle. It is called cardiophrenic angle. What is the next one? What is the next one? Here. This one. What is that? What is the next one? It is something between the lungs and the ribs, or the diaphragm and the ribs. What do you call this? Costophrenic angle. Normally, you will be able to see the angles. Can you see that these are the angles which I'm talking about? These are the angles which I'm talking about. Normally, you should have a clear border of these angles, but here it is not seen. This is what is the number one finding itself. What is it called? It is called blunting. The early finding would be blunting of the what? Blunting of costophrenic or cardiophrenic angles. Okay, blunting of the costophrenic or cardiophrenic angles. Okay, blunting of the costophrenic or the cardiophrenic angles. That is what is the early sign. That is what you need to remember. Please make a note of this. Second thing you can remember is something like this. I told you that white spaces are representing the fluid. Okay, and as the amount of pleural fluid increases, what you will have is something like a curve like this, which will all represent the amount of fluid in the pleural fluid. Okay, any idea what is this curve called as? It is something like a curve which is like going upwards towards the apex or the axillary area. What do you call this curve? You call this curve as a Ellis curve. Okay, you call this curve as a Ellis curve. Ellis curve. Okay, Ellis curve will be seen in large effusions. It will be seen in massive or large effusions. That's what you need to remember. So two important X-ray findings. These are the limited pictures I have. So which is what I am sharing it with you. Yes, costophrenic angles and cardiophrenic angles will be blunted. And in late cases, when so much of fluid accumulates, you will get a curve called as a Ellis curve, which will be pointed towards the apex areas. Are you able to follow this? Everybody able to follow this? Right, correct, doctors, correct. Yes, very good. Okay, yes, correct. I hope you're able to follow this, correct? Okay, now this will be possible only when minimum how much amount of fluid is present? 300 ml of fluid is present. Suppose you have very less amount of fluid, you cannot detect it on the PA view of an X-ray. So what you will take for a minimal fluid? For minimal fluid, what X-ray you will have to take is something called lateral decubitus X-ray. It is very simple. It is not like the patient is straight. You will ask the patient to lie to one side. Okay. Suppose you are thinking of pleural fluid on the right side, you'll ask the patient to lie down on the right side. If you are thinking of pleural fluid on the left side, you'll ask the patient to lie down on the left side and then take the X-ray. That is what is called decubitus. Decubitus means like lying down position. Okay. And what you can see in that X-ray, some minimal fluid is being thinking, right? So think like this. This is the left side of the patient, and the patient is lying towards the left side. Like this, he is lying. He is lying towards the left side. And can you see small amount of fluid will get collected in this area? This is the fluid which I am talking about. It's a small fluid which is going to the side when the patient is lying on the affected side. Are you able to understand this? Okay, and this lateral decubitus view will detect small amount of fluid as little as 100 ml also. As little as 100 ml. That's what you have to remember. Okay, so this is for lateral decubitus view. Okay, then the last one, what is that? What is the best investigation for detecting minimal pleural effusion? Minimal means even less than 100 ml also. Even less than 100 ml also. Any idea? What is the investigation we have to do for detecting very, very minimal amount of pleural effusion? You cannot detect it on an X-ray. You cannot even detect it on a lateral decubitus view. Lateral decubitus view, minimum 100 ml. I'm saying less than 100 ml. In this case, it will be ultrasound, USG. It is going to be ultrasound of the particular chest you can see. And what is that in the ultrasound you can see? You can see the fluid very clearly. And in the ultrasound, you can also differentiate whether it's a transudate or an exudate. Any idea? Transudate or an exudate. Any comments? How can you differentiate on an ultrasound whether it's a transudate or an exudate? Very simple. I told you in exudate, lot of protein will be present. That protein will be seen as floating densities. That protein will be seen as floating densities on a USG. Whereas transudate, you will see a clear, clear area. You will see it as a clear fluid. Fluid is generally called as hypoechoic areas. You will see clear hypoechoic areas in case of transudates. And in exudate, you will see densities. Means some irregularities you will see. That is what we call densities. And that densities represent the amount of protein in the ultrasound. That is what. Yes, Dr. Shirley, correct. Yes, that is correct. Okay, fine. Is it clear? Okay. Able to follow this process, right? Okay, right. So this is what is the investigation which we can do to detect the pleural fluid. Okay, fine. Finally, how are you going to manage these patients? Very, very simple. If it is a transitate, what do you have to do? If it is a transitate pleural effusion, you have to manage the underlying condition. If it's a transitive pleural fluid, think like this. It's a heart failure patient, renal failure patient. You manage the underlying condition or you treat the underlying condition. This condition also will get settled. Treat the underlying cause. That's all. Treat the underlying cause. This condition will get settled. If it is a transitive pleural effusion. Okay, right? But if it is expirate, sometimes you may have to remove that fluid. If it is an expirate, you may have to remove the fluid. Tell me, how can you remove that fluid? Very simple question. How can you remove the fluid? You have to put a something like a tube inside and drain out the fluid. What is that? ICD drainage. ICD drainage. Okay, ICD drainage is indicated for all types of expirated pleural effusion because there is usually little severe type of effusion. So we have to take out the fluid outside. So ICD drainage is recommended. For transudate, you just treat the underlying cause, everything will be fine. But if it is expirate, you have to put the tube and drain out the fluid. Are you able to understand this? Right? Okay, fine. So that is about this particular differences between transitate and exudative pleural effusion. Now, one special topic is there in this pleural effusion, which is about a condition of pneumonia with pleural effusion. And there are three terms I have written, correct? Can you see that? Synpneumonic effusion, parapneumonic effusion, and empyema and all. Sometimes what happens is that you tend to get confused, okay, between these two conditions, okay, between these three conditions, okay. I will tell you an easy way of remembering how you will remember these names, okay. Synpneumonic effusion is something like due to reactive changes in pneumonia, okay, due to reactive changes. See, a patient with pneumonia has disease in the form of infection of the lungs, right? And due to that disease, there will be some inflammation. If that inflammation spills over into the pleura, it can also cause pleural effusion. That is what we call reactive changes. It is something like spillover. Something like spillover. What is the meaning? The lung infection or inflammation is spilling over into the pleural fluid. That is called spillover or reactive pleural effusion. That's all. And for reactive pleural effusion, no treatment is required. You don't need to separately treat it. Okay, it's something which will settle as you treat this particular condition. Okay, as you treat pneumonia, when the pneumonia settles, the pneumonic effusion also will be settling. So this is something which is very benign. You don't need to worry about this condition. That is what I'm trying to tell for pneumonic effusion. Then what is the meaning of parapneumonic effusion? The parapneumonic effusion is here not only inflammation, even the bacteria. Think like it's a bacteria causing pneumonia. That bacteria itself entering into the pleural cavity. That's what I'm writing. Bacteria plus in the pleural cavity. That's what I'm trying to write. What is that? Even the bacteria enters into the pleural cavity. Then it is called parapneumonic effusion. Are you able to follow this? Presence of bacteria in the pleural cavity or the organism in the pleural cavity is called parapneumonic effusion. And then what is empyema? Okay, empyema. Always remember this. Pi or empy like that you see, it is something like pus. It is something like pus. So in the parapneumonic effusion, there is also presence of pus in the pleural cavity. Then you call it as empyema. Are you able to understand this? So you can see as the condition increases, okay, as a condition extends from one stage to another. Pneumonic is not a very difficult thing or a very important one. It is just a associated condition. Parapneumonic is little severe. Empyema is even more severe condition. Okay, are you able to follow this? Okay, so this is how we will differentiate all these things. Okay, the point to be noted is pneumonic effusion. I have already told you no treatment is required. Correct? Pneumonic effusion, no treatment is required. Why? Because as you treat the pneumonia, pneumonic effusion also will settle. Whereas parapneumonic effusion and empyema, it requires treatment. What is that? You have to put a ICD drainage. You have to do the ICD drainage. Are you able to follow this? Of course, as a part of treatment, you will also give antibiotics. You will also give antibiotics. But the point to be noted is antibiotics should be given for a long period of time. Around 3 to 4 weeks, you have to give the antibiotics. That is the point. Okay, so pneumonic effusion, don't treat it. Parapneumonic effusion and empyema, you have to put ICD drainage in addition to antibiotics. I hope you're able to follow this. Clear out this? I hope you're able to follow this. Okay, fine. Now, if you're doing a pleural fluid analysis, okay, if you're doing pleural fluid analysis, how will you differentiate between these two conditions? That is what I want you to remember. See, parapneumonic effusion and empyema will be almost the same only. Only thing, in empyema, as you take the fluid itself, what will be present in empyema? Pus will be present. That is the easy way to differentiate. But you can have some confusion between sympneumonic and paramnemonic effusion. For that only, I want you to know the table of differences. What is that? Sympneumonic effusion, the pH will be normal, like more than 7.3. Whereas paramnemonic effusion, it will be acidic, less than 7.3. That's what you need to remember. Acidosis will be present. Then, of course, sympneumonic effusion, I told you that it is only inflammation spilling into the pleural cavity. So, will you get positive culture, positive gram staining and all? Not at all. Whereas paramnemonic effusion means, I told you, bacteria itself is entering into the pleural cavity. So, definitely culture will be positive, gram stain also will be positive. Then LDH, I told you, sympneumonic is just a spillover of inflammation. So, the levels will be less than 1000. It will be like less increase. Whereas paramnemonic effusion is a proper infection with inflammation, so it will be more than 1000 units per liter. Please have this in mind. Sugar levels, I told you, sugar levels low will be a reflection of severe infection and inflammation, which will be encountered in paramnemonic effusion. Level will be less than 60, whereas sympneumonic effusion, the level will be more than 60. That's what you need to remember. So these are the differences between paramnemonic effusion and sympneumonic effusion. And don't forget, while you're doing the pleural fluid analysis, presence of pus will indicate that it is not only paramnemonic effusion, it is going into empyema. That is what it is. So that is what I've written, like a clinical clue I have written. Suspect empyema in a patient with pneumonia who has fever for more than 5 days, even after you start the correct antibiotics also. So normally, if it is a pneumonia and you start the proper antibiotics, within 2-3 days itself the fever will start coming out. But empyema occurs, the fever will start getting extended. What is the importance if you know it is empyema? The point to be noted is empyema requires ICD drainage along with antibiotics for a long period of time. How long I told you? 3 to 4 weeks of antibiotic is recommended. Generally for pneumonia and all, we give only 2 weeks of antibiotics. But if it is empyema, you have to treat for 3 to 4 weeks. This management part also I have already covered. Are you able to understand this? So this is a special topic of pneumonia with pleural effusion. Please try to understand the differences between the terms sympneumonic, paramnemonic, and empyema. I hope you're able to follow this because the same type of wording can be given in your options also. You should not get confused. That is why I wanted to make it like a separate topic and want you to remember about the same. Is that clear, everyone? Are you able to follow this? Are you able to follow this? Okay, right. So that's about pleural effusion and pneumonia, which I wanted to discuss. So if you see in this session, I have discussed only about these two topics because these are very, very important for your exams going forward. So I want you to know how to have a good clarity about differences between all these conditions. Clear? Okay. Now we have one more condition which is left with, not one more, like one more big topic and small topics like that after that. Maybe we'll have a short break like that around 15 minutes, and then I will start by around 4:30 or like that. And today class will be till around 5:30, 5:45 like this. Okay, I got a message that your ortho class the evening has been cancelled, so you can utilize the time after the class for your, reading about this particular same chapter itself. Okay, fine. Okay, all right. So I will give the break now and we'll resume in 15 minutes. Okay, fine. Okay, so can we get started? Okay, fine. Yeah, so let us get started. Yes. So as you can see in the screen, the next one is like a short topic actually. It's like a short summary of something like clinical examination finding in different lung conditions, okay? In different conditions. Because I have seen in your questions also, like a short scenario they give, and they give you something like a combination of these findings, and they can ask you, what is the condition you are dealing with? Something like that I have seen many times in your questions. And this is something like a common question which we ask for the Indian graduates also. Whenever they present a respiratory system case, we ask some findings like this, and we will ask them, okay, when you have a combination of these findings, what will be your diagnosis like that? Okay, this is what is the same thing also. You can see that something like I am discussing in terms of tracheal deviation, breath sounds, vocal resonance, percussion note, all those things. Okay, right. Now, 4 conditions I have taken up for discussion. What are the 4 conditions? Consolidation, lobar collapse, pleural effusion, as well as pneumothorax. Now, this is for you to answer. I think all of you can take part in the discussion. Okay, whatever you find it relevant, you can just tell me. Okay, right. First one, we will start with the consolidation. We have just completed the topic of consolidation. Consolidation is a word which I am using for pneumonia. So you think like this: lobar consolidation or lobar pneumonia, like that. And you tell me whether this condition you will have any tracheal deviation. Whether you will have any tracheal deviation. What is your answer? Will you have any tracheal deviation, doctor? See, tracheal deviation will occur whenever there is a mediastinal shift. I think you can, you know about the concept of mediastinal shift. What is that? If there is a structure which is pushing to one side, you will have a mediastinal shift, or you have a problem which is pulling to one side, you can have a mediastinal shift. Do you have any such mediastinal shift in case of pneumonia? Absolutely no. There is no mediastinal shift at all. It is only pus inside the lungs. That's all. So you will not have any tracheal deviation. There won't be any tracheal deviation. Okay, right. Now, what do you think will happen to the breath sounds? I told you. Breath sounds will be what? Breath sounds will have a different character. What is the character of the breath sound I told you? It is the bronchial breath sound. Do you remember a loud sound which I have told you? Bronchial breath sound. This is supposed to be the best sign out of all the different signs. This is an important MCQ question. The best sign among the different signs which you get in case of pneumonia, it is the bronchial breath sounds. Okay, right. So next one you can answer. What will happen to the vocal resonance? I told you. Pus is a good conductor of sound, so the vocal resonance will be increased. Okay, very simple. The vocal resonance will be increased. Even I told you that even when the patient is whispering, also you can hear that very clearly with the help of stethoscope. I told you. You remember the wordings I used like whispering, pectoraloquy, and all. Same thing here. Okay, it will be increased. Percussion note. What will happen to the percussion note? I told you, because of lot of lot of pus inside that. What will happen to the percussion note? Normally it's a resonant note, but here it is going to be a dull note. That is what I told you. Okay, note will be dull. That is what I told you. Next is a condition called lobar collapse. So collapse is something like loss of volume. Loss of volume. This lobar collapse can be due to any reason. It could be due to something like fibrosis of the lung, or it could be something like atelectasis. That is what is the word we use for collapse, atelectasis and all, which can be very rarely encountered, not a common clinical entity, but still as a differential you have to remember. Collapse means there is loss of volume in one particular area of the lung. So you think like this, okay? Air is not even entering into that area. So what do you think will be the, what do you think will be the tracheal deviation? Think like this. This is the left side of my lung. In that left side, I'm saying the upper lobe is completely collapsed. Think like this. The upper lobe is completely collapsed. Think like this. In my left side, upper lobe is completely collapsed. If the upper lobe is going to be collapsed, what will be the problem? That area, there is a loss of lung volume. So what happens? It will pull the trachea towards this side. Are you able to follow this? So definitely, tracheal deviation will be present. Tracheal deviation will be present towards the collapsed lung. Towards the collapsed lung. For example, my left side lung is having a lung collapse. The trachea will be pulled towards left side only. I hope you're able to follow this, okay? And this is supposed to be the best sign for lung collapse, okay? Tracheal deviation. This is supposed to be the best sign. What about the breath sounds? Very simple. Whenever there is collapse, do you think breath sounds will be heard properly? Not at all. The sounds will be decreased. What about vocal resonance? What about vocal resonance? Whenever that area is completely collapsed, see, this area is completely collapsed. If I keep the step over that area, will I be able to hear the sounds? Not at all. The vocal resonance will be decreased. What about the percussion note? Again, percussion note will be dull only. Percussion note will be dull because you don't have a good amount of lung there. Okay, so dull note. Very correct. Okay. Then what about pleural effusion? Do you think an answer? Pleural effusion, usually there is no tracheal deviation. However, in case of massive pleural effusion, think like this again. So much of pleural effusion, like 1 liter, 2 liter of fluid is there. What do you think will happen? Suppose my left side is having pleural effusion. So much of fluid is there on the left side of the lung. What will happen? It will push the trachea towards the opposite side. Are you able to follow? When so much of fluid is there on the left side, it will push the trachea towards the opposite side. So I can write, if it is a minimal pleural effusion, no problem. But if it's a massive pleural effusion, there will be tracheal deviation towards the opposite side. Towards the opposite side. That is what you need to remember. It will be towards the opposite side. Okay. What do you think will happen to the breath sound? Do you think the lung sounds can be heard clearly through a fluid area? Not at all. It would be decreased. Definitely, it would be decreased. Vocal resonance, again, it would be decreased only because fluid will not be able to conduct very properly through the, fluid, the air will not be able to be conducted properly through the fluid. So again, vocal resonance will be decreased. What about percussion? Where are you percussing? You are percussing over a fluid area. Definitely, this will also create a dull note. In fact, it is very, very dull. This is what we typically call it as a stony, dull percussion note. And this is supposed to be the best sign of pleural effusion. Very important again. This is supposed to be the best sign of pleural effusion. This is a stony, dull note because fluid is there, correct? Definitely it will be dull and it will be very dull also. That is what I call it as stony dull. Okay, then pneumothorax. I think all of you know pneumothorax means what? Air is accumulating inside the lungs, okay, or air is there in the thoracic cavity. Air is there in the pleural cavity. It is called pneumothorax. So will it cause a pleural effusion? Usually pneumothorax, no. But if it is a massive pleural effusion, any of you know what is the word for this massive pleural effusion? It is called tension pneumothorax. In your surgery classes and all, you will be learning about this. For example, road traffic accident cases and all, patient can have pneumothorax. That time they will be discussing about tension pneumothorax, which is something like massive pneumothorax. So think like this, what is happening? Think like my left side, there is pneumothorax. What is that? So much of air is accumulating in the pleural cavity on the left side. So what happened? It will push the trachea towards the opposite side. So definitely in tension pneumothorax, definitely tracheal shift will be present, but towards the opposite side. Very simple, towards the opposite side. That's what you have to remember. Okay, minimal, no problem, but massive, like tension pneumothorax, it will be definitely there. Then what about the breath sounds? Doctors? Very simple question. What do you think will happen to the breath sounds? See, this is where you have to be careful. What will be the breath sound? Will you hear them normally or it would be decreased? Breath sounds. Very simple. Just a minute. Yeah, very simple question. What will happen to the breath sound? Again, there is a lot of air in that area obscuring the lung fields. So breath sounds will be definitely decreased. Without any doubt, breath sounds will be decreased. What about vocal resonance? This is where your MCQ question. What about vocal resonance? See, just a minute. The characteristic feature will be the best sign, or the best sign you can remember is the breath sounds only. Okay, breath sounds will be decreased. Okay, and fine, you can also remember. What do you think will happen to the vocal resonance? Vocal resonance also will be decreased only. Okay, very simple. Vocal resonance will be decreased. What about percussion note? What about percussion note? See, percussion note is something like you're tapping like this, right? Okay. Now here, what is accumulating? I was telling you here, air is accumulating. So much of air is accumulating. So you tell me what will happen to the percussion note. The percussion note will be very, very hyper resonant. Okay, it is called as a hyper resonant percussion note. See, very simple. You think like this. There is air inside the lungs, and surrounding that lungs, you have the lung parenchyma also. So that is why you are hearing this type of sound. Okay, that is called resonant note. Here, what is happening? So much of air is there, and there is no covering also. So when you just percuss over that area, you will hear resonance, but too much of resonance. That is what is called as a hyper resonant note. And please make a modification. This is supposed to be the hyper resonant note here is supposed to be the best sign. This is supposed to be the best or the characteristic sign of pneumothorax. You will get hyper resonant notes. Are you able to follow? It is called hyper resonant. Very correct. Yes, yes, very good. Hyper resonant note is supposed to be the best sound. Okay, right? Are you able to follow this? Hyper resonant notes. Okay, clear? Okay. So please remember, yes, very good. I hope many of you are able to get the findings correctly. So please remember, I have made a compilation of differences in the clinical findings between the different lung conditions, and everything can be put up like individual scenarios also. Okay, right? And they can give you a combination of these findings, and they can ask you, what is this condition you are dealing with? Like that also you can get questions. So please make a note of all these. What I would be doing is, after I finish the today's class, I will send over some MCQs. I will send over some MCQs to your coordinators. They will sharing that file with you, and you can practice all those MCQs. And for tomorrow's discussion, when I start the discussion, I will be first doing that MCQ discussion, and then I will come back and then I will start the next topic. Fine? Okay, right. So I hope you're able to follow this. So very simple. Consolidation. The main sign is bronchial breath sound. Collapse, the main sign is tracheal deviation, but very important, tracheal deviation towards the collapsed lung field. That is important. Pleural effusion, the best sign is stony, dull note on percussion. And pneumothorax, the best sign is hyper-resonant note on percussion. I hope you're able to follow this. So please try to remember all these things and try to answer accordingly. Clear? Okay. Now we move on to the next topic, which is starting like a short scenario like this. You have a 65-year-old lady who suddenly dies in the ward after a surgery of the fracture of femur. Okay, right? After surgery of fracture of femur. So this lady had a fracture of femur surgery. She was in the post-operative ward, imagine like this, and unfortunately, she suddenly dies. Okay, while having lunch in the post-operative ward. What would be the most likely cause? This is a situation of sudden death scenario, and look at that history. It is something after a surgery. See, you know that this is a surgery which is a limb surgery, correct? Fracture of the limbs. So obviously, in the post-operative period and all, you will immobilize the patient. You will immobilize the patient. Obviously, she cannot walk following surgery on a fractured femur. Okay, very correct. Okay, very correct. And what you will see is that this immobilization itself is one of the risk factors for a condition which can cause sudden death. Okay, I can see some options. Some of you are saying fat embolism. Some of you are saying pulmonary embolism. Which will be the answer? Okay, see, this is a close differential actually. This is a close differential between fat embolism and pulmonary embolism. See, fat embolism will be the answer if it is only fracture femur which is given, and following that the patient had death and all, you can think about fat embolism. That's okay. But here, what is it? Surgery has already been done for fracture femur, and after that only the patient is dying. This is more in favor of pulmonary embolism. Okay, always you will have a question. Always you will have a question like whether it is fat embolism or pulmonary embolism. Please remember, immobilization is an important factor for pulmonary thromboembolism. The complete name is like this: pulmonary thromboembolism. Please don't forget this. In short forms, remembered as PTE. Okay, I'm going to explain that only. Okay, I'm going to explain that only. I see many of the answers there. Very happy for that. Even this time also in your January exam, we had a question from pulmonary thromboembolism only, right? So you should know about this. The typical risk factor would be in the form of immobilization. That is what you have to remember. This is the typical risk factor. Okay, in the form of immobilization. I'll talk more about the immobilization shortly. So first of all, it is something like this: embolism, which is coming from a thrombus in some other part of the body. It is not that in the lungs only there is a thrombus which is formed. No, thrombus is formed in some other part of the body, and from a part of the thrombus becomes detached, and that forms an embolus and comes to the pulmonary circulation and blocks it. That is what is called pulmonary thromboembolism. Now the question is, what is the source of the thrombus? What is the source of the thrombus? Any comments? What is the source of the thrombus? Anybody? Where do you think this would have come from? Yes. Where do you think this would have come from? This would have come from the, what is the most common? It is DVT. What is that? Deep vein thrombosis. It is from deep vein thrombosis. It would have originated. I think all of you must have heard about these topics in your surgery classes, right? DVT, okay, deep vein thrombosis and all. Yes. It would be something like small thrombus which are found in the leg veins and all. They can become detached and they can form an embolus and come to the pulmonary circulation. So the most common source is deep vein thrombosis. It is usually in the area of the lower limbs. Okay, this is the most common source. Any other source? This is most common. I have already told you that. Any other source can anybody tell? Any other source can anybody tell this? Any other source? Something like an ICU patient where you are putting a central IV catheter, central venous catheter. Think like this. You have an ICU patient who is having a central venous catheter. Yes. That could be also a source of this thrombus. Very good. Okay. That could also be a source of the thrombus. Okay. And what is that source? Central venous means which area I'm talking about? I'm talking about the jugular veins. Okay. Talking about the jugular veins. Talking about the jugular veins. Yes, Dr. Nixon, you are saying if it is immediate cause, it could be fat embolism. Yes, usually fat embolism, if at all death occurs following the event, for example, this fracture itself, within 48 hours or maximum 70 hours itself, the death will occur. But pulmonary embolism will be like patient will be immobilized for a long period of time, like around 5 days, 7 days, like that. Then only this condition will be occurring. I hope you are able to get that point. Fine. Yes. It is like sudden death following a fracture or something like a road traffic accident, something like that. Then you can think in terms of fat embolism. Pulmonary embolism will be a little later, for example, 5 days to 7 days will take. Okay, fine. Okay, okay, right, fine. So, yes, very good. That is what you are saying. Correct. What is that? Yeah, central venous catheter, that is the jugular veins can be the next thing. And third important thing is in pregnancy. I think all of you know, in pregnancy, what happened? The uterus becomes enlarged So to provide the blood supply to that area, the pelvic veins also will become increased in size. And during the time only, the pelvic veins can develop a thrombus inside them. So due to occlusion as well as increased pressure during pregnancy, pelvic veins can also form a source of thrombus. So three important areas I have told you. One is the deep veins of the lower legs. Second is the jugular veins as a part of central venous catheterization. Third is the pelvic veins as a part of pregnancy. Okay, these are all the areas where you can get thrombus from, and that thrombus, once it comes into the pulmonary circulation, it can result in the this thing. Okay, it can result in pulmonary thromboembolism. I hope you're able to follow this, right? So most common source I told you is deep vein thrombosis. And what is the reason for the deep vein thrombosis to occur? It is basically due to immobilization. This is the most important risk factor for for the deep vein thrombosis to occur. So in your exam, the clue for pulmonary embolism would be some form of immobilization which is given. Usually it is like that, some form of immobilization which is given. So what is the immobilization which I have told in this particular question? It is post-surgery. Post-surgery, right? Especially which type of surgeries the patient will be immobilized for a long period of time. It is the limb surgeries only or orthopedic surgeries. I hope you're able to follow this. It would be orthopedic surgeries. Post-surgical, especially orthopedic surgeries, that's what you need to remember. Anything else, any other condition, patient will be immobilized for a long period of time. Patient who are having a chronic heart failure, that is what some of you are saying, no, for pulmonary and all. Any patient who is having a chronic heart failure, they can also not have a normal activity, because chronic heart failure patients, even if they do any activity, they have this what is it? They have this dyspnea and all, so they will not move around for a long period of time. That also predisposes to this one condition. I hope you're able to follow this. I hope you're able to understand this. Why not for pulmonary? It can also be a factor, but rarely. Okay, right? So chronic heart failure or pulmonary can be there. And third thing would be prolonged air travel also. Prolonged air travel also. Think like taking a long flight where you are immobilized for a very long period of time. There also, immobilization is occurring, and there also you can get this particular thing. I hope you're able to follow this. These are all some of the important things which can be given as clues in your exam. And the most important clue you should always be remembering about is the post-surgical condition. I hope you're able to follow this. Okay, it would be the post-surgical condition. Now, this is what is the usual thing. Next thing, what you have to remember, polytrauma patients also, correct? Okay, next thing you have to remember is there is something called inherited conditions. These are all inherited conditions called as a thrombophilia conditions. Okay, something like a condition which can be either inherited or rarely acquired also. A condition called as hypercoagulable states. A condition called as a hypercoagulable states. Hypercoagulable states where the patient has an increased risk of thrombosis. Thrombosis. That means the patient has a tendency to develop high amount of thrombus in the circulation, and that can result in thromboembolism also. What are these conditions? These are purely like pathology related discussions only. I think all of you know, for thrombus to occur, there should be something called clot formation will occur. So think like this: a condition where you have excess of clot inside the body, there will be excess of thrombus formation also. Can any of you know what are the inherited condition which can be associated with excess thrombus formation inside the body? Anything inherited condition where there can be excess thrombus inside the body? Any condition, inherited condition. It's a pathology related thing. Has pathology been taken or not? Pathology been taken or not? Okay, fine. Pathology is not yet over. Fine. That is okay. Now, the point of which I wanted to say is, you all know about the normal clot formation, correct? It is like the platelet will come and attach. Then you have clotting factors which will become activated, and then only the clot is formed. Normally, what happens whenever you have a break in the body, then only this clot formation should occur. That is what is a normal thing, right? Which occurs normally whenever there is a break in the body, this clot formation will occur. Suppose even without breaks in the body, there is a lot of clot formed inside it. Then we will call it as a thrombophilia condition. And what are the conditions and what are the risk factors for this? One is a condition called these are all inherited conditions called factor V Leiden mutation. Factor V Leiden mutation. Factor V Leiden mutation. Okay. Then one more condition called protein C deficiency and protein S deficiency. Third one is called antithrombin 3 deficiency. Antithrombin 3 deficiency. These are all inherited conditions which can predispose the patient to develop recurrent thrombosis, and as a part of that, thromboembolism can occur. All these things appearing to be very new to you. Do you want me to explain this? Do you want me to explain this factor V Leiden mutations and all these protein C, protein S deficiency and all? Do you want me to explain this, or it has been already taken for you? Hypercoagulable states where the patient has an increased risk of thrombosis. thrombosis. That means the patient has a tendency to develop high amount of thrombus in the circulation, and that can result in thromboembolism also. What are these conditions? These are purely like pathology related discussions only. I think all of you know, for thrombus to occur, there should be something called clot formation will occur. So think like this: a condition where you have excess of clot inside the body, there will be excess of thrombus formation also. Can any of you know what are the inherited conditions which can be associated with excess thrombus formation inside the body? Anything inherited condition where there can be excess thrombus inside the body? Any condition, inherited condition. It's a pathology related thing. Has pathology been taken or not? Pathology been taken or not? Okay, fine. Pathology is not yet over. Fine. That is okay. Now, the point of which I wanted to say is, you all know about the normal clot formation, right? It is like the platelet will come and attach. Then you have clotting factors which will become activated, and then only the clot is formed. Normally, what happens whenever you have a break in the body, then only this clot formation should occur. That is what is a normal thing, right? Which occurs normally whenever there is a break in the body, this clot formation will occur. Suppose even without breaks in the body, there is a lot of clot formed inside it, then we will call it as a thrombophilia condition. And what are the conditions which, and what are the risk factors for this? One is a condition called, these are all inherited conditions called factor V Leiden mutation. Factor V Leiden mutation. Factor V Leiden mutation. Okay. Then one more condition called protein C deficiency and protein S deficiency. Third one is called antithrombin 3 deficiency. Antithrombin 3 deficiency. These are all inherited conditions which can predispose the patient to develop recurrent thrombosis, and as a part of that, thromboembolism can occur. All are these things appearing to be very new to you? Do you want me to explain this? Do you want me to explain this factor V Leiden mutations and all these protein C, protein S deficiency and all? Do you want me to explain this, or it has been already taken for you? Has it been already taken? This factor V Leiden protein C, protein S and all? Is it taken or not? All these conditions. Okay. So in that case, what I will do is I'll just take a small picture, okay, right? And I will try to explain it to you, okay, because some of you are not able to, like follow it up. So just a minute. I'll just stop the screen sharing for a minute, and then I will take the. Okay, so in pathology, you're saying it has already been discussed, okay. But anyway, just for a quick revision purpose, I will just put this, okay. Just see here, just a minute. I'll start the screen sharing. Okay, so see here, this image, okay, see here. See, just a minute. Okay, fine. So you see this particular thing. Okay, this is the factor V Leiden which I want you to take a note of. Okay, see, I think all of you know the clotting factor pathway, extrinsic pathway, intrinsic pathway. I think every one of you know about this. Okay, now what happens when we move towards the common pathway and all? What is happening? This factor 10 and factor 5. Can you see that the factor 10, the factor 10 as well as the factor 5 are involved in this common pathway. What will happen? They become activated. That is what is 10A and 5A. They become activated. And then they convert this PT. What is that? Prothrombin into TH. What is that? Thrombin. And following that thrombin only, what is that? Fibrinogen will be converted to fibrin. And then we have a stable clot formation. Are you able to follow this? I think this is the normal thing which most of you should be knowing about. Okay, which I think all of you must be knowing about this. Okay, right. This is normally happening. Now what happens? You see this protein. What is this protein? It is protein C. Now this protein C, what does it do? The role of the protein C is to inactivate the clotting factors. What are the clotting factors? Factor 8 it will inactivate, factor 5 also it will inactivate. So you think like this, whenever the clotting requirement is over, protein C will come in and protein C will inactivate the factor 8 and factor 5. Normally in our body, this is going to be inactivated, okay, with the help of protein C. And another protein which will help the protein C in its action is protein S. So what I'm trying to tell you, both these protein C and protein S, okay, protein C and protein S help to inactivate certain clotting factors whenever there is no need. Now think what will happen whenever there is a protein C or a protein S deficiency. What is going to happen? These clotting factors will not be inactivated. When the clotting factor will not be inactivated, what will happen? All these steps will occur without any inhibition, and this would result in excessive clot formation. And this excess clot formation will result in thromboembolism. I hope you are able to follow this. Excess clot formation will result in thromboembolism. That is why this condition predisposes to recurrent thromboembolism, protein C and protein S deficiency. Then what's the next one? Factor V Leiden mutation. What is the meaning of this factor V Leiden mutation? Normally, I told you factor V can be inhibited by protein C. Whenever there is a mutation, factor V Leiden mutation occurs, this factor V will not be inhibited. Will not be inhibited by protein C. Are you able to follow this? So even if protein C is present, whenever factor V Leiden mutation is present, that factor will not be inhibited. So when that factor is not inhibited, again all these steps will occur, and again excessive clot formation will occur, and again thromboembolism is going to occur. So that is why we always say that all these problems are going to result in excessive thromboembolism. I hope you are able to understand this. Then one more point is like this. What is that? The one more point is, sorry. One more point I told you, antithrombin 3. I think antithrombin 3, all of you must be knowing. Antithrombin 3 is an anti-clotting protein which will inhibit the thrombus formation. When antithrombin 3 is going to be decreased, what is going to happen? Excessive clot will form, and thereby there will be thromboembolism. I hope you are able to understand this. This is what I want you to remember for all these inherited conditions associated with thrombophilia. And please remember, the most common inherited condition with thrombophilia is going to be factor V Leiden mutation. This is an important MCQ question. Please make a note of this. I hope this is clear. Okay, right. Then acquired condition. Anybody wants to say some acquired condition? It is something like usage of OCPs. What is that? Oral contraceptive pills that can lead on to acquired this thing. And one more condition called APLA syndrome. Any idea what is this APLA syndrome called? It's a condition called antiphospholipid antibody syndrome. Antiphospholipid antibody syndrome. Wherein also these antibodies will result in increased production of this particular thrombus formation in the body, and that can lead on to thrombosis. Okay, so what I'm trying to tell is two important categories of risk factors can result in pulmonary thromboembolism. One is patient with immobilization. That is the most important clue for your exams. And second thing is any patient who has thrombophilia risk. That means a tendency to develop increased thrombosis inside the body. They can also develop pulmonary thromboembolism. Are you able to follow this? Usually, in most of your questions, it will be something related to immobilization, which will always be given in your question. So now let us see what are the problems due to this pulmonary embolism. You can either write in this page or you can write in the next page also. Not a problem. Okay, you can continue writing. See, think like this. This is the alveolus. This is the alveolus. And this is the blood vessel, which is like this. This is the pulmonary capillary, which is like this. Now what happened? Think like you have a embolus, which is blocking the artery like this. You have an embolus, which is blocking the artery like this. So what will happen? Whenever there is a block in this area, what would happen to the blood flowing? There will be decrease in the blood flow to that area. There will be decreased blood flowing in this after the blockage. Okay. So do you think the oxygen which is coming into the alveoli can easily enter into the blood vessel like this? Not at all possible, because there is already a block here. So because of the block, the oxygen cannot enter into the body. So this is going to result in what? This is a sudden blockage, correct? So this is going to result in sudden hypoxia. And that hypoxia typically manifests as patient becoming suddenly breathless or dyspnea. Sudden dyspnea will be there. This is supposed to be the most common presenting feature. Okay, sudden breathing difficulty. So you think like that. That patient whom we were talking about, she was a post orthopedic surgery patient. She was just taking her food in the lunchtime in the ward. Suddenly, she might have felt breathless, and she would have died very soon after that. So this is something which is important. It's a sudden onset presentation. This would be the sudden onset presentation which you should keep in mind. Okay, in the form of sudden breathing difficulty. And when you see the patient, he'll have fast breathing also, or tachypnea. And another feature, very rarely only, they can have pleuritic chest pain also. Suppose what happened? Pleuritic chest pain. What is that? Suppose that area affected is near the pleura. You can even have pleuritic chest pain also. I hope you are able to follow this. Okay. And because of the decreased blood flow, what you will have? You will have decreased blood flow, and this is what we call it as oligemia of the lung fields, which are noted. That is the point. I will come back to this point little later also. Oligemia of the lung fields. Little later I will come back to this point. Okay, fine. Okay, all right. Just a minute. Just 1 minute. Just 1 minute. Just give me 1 minute. There is something here. I'll be. So I will just do a quick recap of what I was telling you. I was just trying to tell you that whenever there is a block, pulmonary embolism means what? That embolus is blocking the pulmonary circulation. Are you able to follow this, right? Whenever there is a block in the pulmonary circulation, what is going to happen? One, blood flow to that lung will be affected, number one. Number two, what is going to happen is that because of the decreased pulmonary blood flow, there would be sudden hypoxia, and that sudden hypoxia classically manifests as dyspnea. That is number one. Number two, due to decreased pulmonary blood flow, you will also have affected area which will show decreased vascular marking, which is what we call oligemia. I will come back to these points a little later. But what right now I want you to remember is the commonest feature would be sudden onset of breathing difficulty in a patient who is having immobilization. Think about pulmonary embolism. That is the point I wanted to convey. Okay. One more important thing is suppose it's a massive embolism. Suppose it's a massive PE or pulmonary thromboembolism, PTE. Suppose it's a massive pulmonary embolism. So think like this. This is a pulmonary artery. Think like this. This is PA, main pulmonary artery. Imagine like this. And it's a very big embolism. Think like this. And it is causing complete block in this particular pulmonary artery. What do you think will happen? No blood is at all flowing to the lungs. No blood is flowing to the lungs at all. And this is something inside the pulmonary artery itself. So whenever there's a big block in the pulmonary artery, what do you think will happen to the pressure in the pulmonary artery? It would be increased. There would be increased pressure in the pulmonary artery. Correct? There is so much pressure inside the pulmonary artery. So which side of the heart will face the pressure to push the blood into pulmonary artery? What is the heart chamber which is pushing the blood into pulmonary artery? What is that? It is right ventricle. So what happened? Right ventricle will face lot of pressure to push the blood into pulmonary artery. So what can happen? It can result in sudden right heart failure also. It can result in sudden RHF means it can result in sudden right heart failure also. This may be one more feature of massive pulmonary embolism. What is that? Sudden right heart failure can occur, and this is going to be associated with increased chance of death. Probably this would have occurred in that particular patient who had sudden death. What could have happened? It could have been a massive pulmonary embolism, which could have caused full blockage of the pulmonary artery and could have resulted in death in that patient. I hope you're able to follow this. Are you able to follow this, right? Yes, that is what you need to remember. Okay, right? Sudden death in that patient. See, remember this pulmonary embolism is a condition which, if you are not very, aware of, you can lose the patient in front of. That is why what I have written, clinical suspicion is the most important step in identification. So, what is the clinical suspicion? You have a patient with immobilization, and if that patient complains of breathing difficulty, always think about the possibility of pulmonary embolism. So, that is what again I am emphasizing. Clinical suspicion is the most important thing whenever you think about a patient with pulmonary embolism. Are you able to follow this, right? And for your exam purpose, just like a one-liner, you remember there's something called Bell's criteria, which is a scoring system to estimate the probability of pulmonary embolism. I don't think Bell's criteria is asked for screening exam level, so you just make a note of this name alone and leave it there. That's all. Okay, right. Next, we see what are the X-ray features in pulmonary embolism. So there's a big gap. I didn't check this formatting. There's a big gap, not needed so much of that. So I'll just tell you what it is, and then I will move on to the next thing. What is it? X-ray, please remember this first point, it is non-specific. You cannot diagnose pulmonary embolism with the X-ray. First point to be noted. You cannot diagnose pulmonary embolism with the X-ray feature. Second thing, X-ray is usually normal in a patient with pulmonary embolism. Okay, usually normal in a patient with pulmonary embolism. That is the point which I wanted to convey. Only in case of big pulmonary embolism or massive pulmonary thromboembolism only, you will get some findings. What are the findings you can get? Any idea? What are the findings you can get in big pulmonary embolism? You think like this. This is the lung fields which I'm drawing. You think like this. These are the lung fields which I'm drawing. And think like this is the pulmonary artery which is entering into the lung. Main pulmonary artery which is dividing like this. You think like this. And in this one branch of the pulmonary artery, there is a complete occlusion. Imagine like this. In this one pulmonary artery, there is a complete occlusion. Now, whenever there is a complete occlusion, what do you think will be the blood flow in the area below? This is the area below, correct? This is the area below. Think like this is the area which is supplied by the pulmonary artery. What will happen? There will be no blood flow at all in the affected area. I hope you're able to follow. There will be no blood flow at all in that affected area. And what do you call this pathologically? What do you call this? Completely blood is cut off to that area. This is what we call it as the area of, what is this area called? Area of infarction. This is what we call it as the area of infarction. So this area will undergo infarction. I hope you're able to follow this. Are you able to understand this? This is the area of infarction. So if you look at this, what will happen? Because of no blood flow, will you see any vascular markings in that affected area? Will you see any vascular markings in that affected area? There will be no vascular markings in that affected area. No vascular markings in that affected area. This is what we call it as oligemia. Oligemia. And there is a named sign for this oligemia. What is the named sign for this oligemia? It is called as a Westermarck sign. Please make a note of this. It is called Westermarck sign. Don't forget this. It is a named sign for no vascular markings in that affected area. It is called Westermarck sign. Second thing, the area of infarction will appear like this. Triangular area. Can you see that outline? This is the outline which I was talking about. Can you see this outline which I'm talking about? It is more like a triangular area, which is what we call it as a wedge-shaped infarction. Wedge-shaped infarction. Any name for this, doctors? Any of you know about this name? Wedge-shaped infarction. The wedge-shaped infarction, it is also called as a Hampton's hump. It is called as a Hampton's hump. Okay, it is called as a Hampton's hump. Okay, so two important signs which I want you to remember. One is called as a Westermarck sign, and second one is called as a Hampton's hump. Westermarck sign refers to the oligemia, and Hampton's hump refers to the wedge-shaped infarction. Are you able to follow this? Right? Are you able to follow this? Right? So, but please remember, all these findings will be only for a big embolism. If it is a big embolism, you can see all these findings. If it is small embolism and all, usually the X-ray will be normal. Or what I am trying to tell you, you don't depend on X-ray to make a diagnosis. Very simple thing. You don't depend on X-ray to make a diagnosis of pulmonary embolism. This is purely for your MCQ purpose. I want you to remember the two commonly asked MCQs are Westermarck sign and the Hampton sign. That's all. That's over. Okay. Next thing, ECG. You can also do the ECG. See, I told you what is the heart area which will be affected. It is the right heart area which will be affected because right heart is the one which is pushing the blood into pulmonary artery against resistance. So what you can get is something called strain pattern. Don't worry about this ECG pattern because in the ECG section of the cardiology, I will be discussing about all these things. So right now, I'm not going to explain anything. I'm just going to tell the name only. That's all. What is that pattern called? Any of you know that? It's called S. Okay, it's already written. What is it? S1, Q3, and T3 pattern. What is the meaning of this? You will get large S get large S waves in lead 1. You will get large S waves in lead 1. Okay. Then you will have deep Q waves in lead 3. What about T3 means? Inverted T waves in lead 3. That is what is called S1, Q3, T3 pattern, which is indicating right heart is undergoing strain. That's all. And again, the point to be noted is it diagnostic of pulmonary embolism? Absolutely no. It is a non-specific finding. In any type of right heart strain also, you can get the same finding. So again, I'm telling ECG is not a diagnostic investigation. So if ECG is also not a diagnostic investigation, then what do you think is the best investigation for diagnosis? This, I think, was this January exam question, 2023 exam question. What is the most specific test or the best test for diagnosing pulmonary thromboembolism? Anybody wants to comment on this? This was this year's exam question. Even I think even 2020 exam, 2021 exam also, they asked about this particular question. What is the best investigation to make a diagnosis? Very good. What is the answer? The answer is going to be CTPA. What is that? CT is a CT or the coronary tomography. And what is this PA? PA stands for pulmonary angiogram. It is CT pulmonary angiogram, which would be the best investigation. CT pulmonary angiogram. So computer tomography with pulmonary angiogram will be the investigation of choice. CTPA is the investigation of choice. Multiple times, repeatedly asked questions. I'm putting a lot of cues there. So many times it has been asked in the exam. Okay, so many times it has been asked in the exams. Fine. Now, you can very easily see, if you do the CT pulmonary angiogram, you can easily see the embolus. I'll show the picture, how it would look like. Okay, see this particular picture? This is how the embolus would look like. This picture. Just a minute. Okay, see here. Can you see that? This is the picture I was talking about. Can you see this is the pulmonary artery? Think like this. This is the pulmonary artery. This area is the pulmonary artery. And can you see this is the outline of the pulmonary artery, which I'm drawing like this. This is the outline of the pulmonary artery, which is beautifully branching into two arteries like that. And can you see this area? Can you see that the one which is black color now I'm shading in yellow color? What is that? That black area is what is the embolus area. That black area is the embolus area. Very clearly, you can pick up the location of the embolus by doing CT pulmonary angiogram. So CT pulmonary angiogram is going to be the best investigation for diagnosis of pulmonary thromboembolism. Please keep in mind, this is a repeatedly asked question. Any other test we can do? Previously, we were using some other test called as VQ scan. Any of you know that? Any of you know that what is this VQ scan? It is something called ventilation. V for ventilation. What does this Q stand for? Q stands for perfusion. Okay, ventilation, perfusion. So what do? You compare the ventilation in the lung and compare it to the perfusion. What happens in pulmonary embolism? Ventilation is normal only, but perfusion is decreased. Embolism means decreased perfusion. So when you have this ratio and all, something called VQ ratio and all, what do you think will happen to the VQ ratio? It would be decreased. That is what is the point to be noted. That number you don't need to write it. Just remember, ventilation will be normal, but perfusion will be decreased in case of VQ scanning. But now this test is actually outdated. We are not doing this test. The only test which we are doing for the diagnosis is CT pulmonary angiogram. Okay. Now, one more thing also you need to know about what is the role of D-dimer. This is something which you can answer from your pathology classes. What will happen to D-dimer and what is the role of D-dimer? See, for this to be understood, we can remember what is it. Whenever there is a fibrin clot which is found inside the body, or a clot is found inside the body, after something, there is something called fibrinolysis. There will be fibrinolysis. That is, the fibrin will get lysed. And whenever the fibrin gets lysed, you will get this FDP. What is this FDP? I think all of you know, fibrin degradation products. And D-dimer also will be formed. D-dimer is like a fragment, that's all. Okay. Now, whenever there is a lot of clot found inside the body, there will also be a lot of D-dimer present. So, in a patient, if you have increased levels of D-dimer, what you may think about? Probably this patient is having a tendency to develop increased clot inside his body. So, first question you can answer, what will happen to the D-dimer level in a patient with pulmonary thromboembolism? First question, what will happen to D-dimer level in a patient with thromboembolism? Obviously, pulmonary thromboembolism is a condition where there is a tendency to form a lot of clot inside the body. So, the D-dimer level also will be increased in this situation. That is the point. Okay, that is the point. Now, answer one question. If I have a patient with increased D-dimer, can I say that this is only pulmonary embolism? Do you think D-dimer is a diagnostic test? Not at all, because D-dimer can be elevated in many other conditions where there can be a tendency to form thrombus. So D-dimer is not diagnostic investigation for this particular condition. It is not at all a diagnostic investigation. Like some of you are saying, no, even in DIC also, disseminated intravascular coagulation also, D-dimer level will be increased. So what is the role of D-dimer then? It is not for diagnosis. What is the role? The role is something called, I'm going to write this, the role of D-dimer is that it has got NPV. What is NPV? Negative predictive value. What is the meaning of negative predictive value? Suppose I am thinking of a patient is having pulmonary embolism, and if I check D-dimer, suppose the D-dimer level is normal. What can I rule out? I can rule out the diagnosis of pulmonary embolism itself. This is what is called negative predictive value. What is the meaning? If the value is normal or less, it rules out the diagnosis. But positive value doesn't always tell it is a diagnosis. So what is the main role of D-dimer? D-dimer helps to rule out the possibility of particular pulmonary embolism. So this is what we call it as a high negative predictive value. Or they can ask you, is it a screening test or a diagnostic test? Answer is going to be, this is only for screening purposes. That is the point. Okay, so two things I wanted to emphasize, or three things I wanted to emphasize from this particular discussion of investigations in pulmonary thromboembolism. What are the three things I wanted to tell you? First of all, ECG and X-ray will not help in the diagnosis. Point number one. Number two, best overall investigation for diagnosis is CT pulmonary angiogram. Point number two. Point number three is D-dimer is only a screening test which will help you to exclude the possibility of this particular condition. D-dimer elevation is not diagnostic of pulmonary embolism. I hope you're able to follow this. Everyone able to follow this? Right. So these are three important points which I want you to remember in pulmonary thromboembolism. Finally, coming to the last part. The last part will be about treatment of a patient with pulmonary embolism. Okay, for the treatment purpose, we divide them into hemodynamically stable patient and hemodynamically unstable patient. How do we say that? It is something based on the parameters like blood pressure, pulse rate, all those things. If it is a hemodynamically stable patient, what will happen? Blood pressure will be normal, his pulse rate will be normal, every vitals will be normal. That is what I'm trying to tell you. Hemodynamically unstable patient means something like this. Blood pressure will be dropping, pulse rate will be increased, something like he may have features of shock also. Are you able to follow this? That's how we have to quickly differentiate between hemodynamically stable and hemodynamically unstable patient. What does it tell you? Hemodynamically unstable patient, generally they have large clots inside the body. That is why they have become unstable. Whereas hemodynamically stable patient, they have small clots inside the body, and it is usually, you don't need to treat it also. You don't need to treat it also. Why? Why I'm saying you don't need to treat it? Because it is only a small clot, right? Hemodynamically stable patient, they have a small clot. It is understood that most of these patients, the clot will be removed by the body itself. You don't need to do anything. That is what it is. So for hemodynamically stable patient, what do is we don't actively remove the clot. We will just observe the patient. But you have to do something else. What is that? Suppose the clot becomes bigger. What will happen? The damage also will become severe. So what is the mode of treatment for a hemodynamically stable patient? I will not remove the clot, but at the same time, I will prevent any new clots are being formed or prevent this clot from becoming bigger in size. So what should I do? Think logically and tell me, what should I do for a hemodynamically stable patient? I will not remove the clot, but I will prevent this clot from becoming bigger or prevent any new clots which are found in the body. So what can I do? Very, very simple. I have to go for anticoagulation treatment. Are you able to understand the concept? If I do anticoagulation, no new clots will be found, or this clot will not become bigger. So what is a typical anticoagulant I can use for emergency setting? Should I use a oral medication or parenteral medication? Obviously, I have to use a parenteral medication, and the common one is low molecular weight heparin, something like this, enoxaparin, all those things, which is typically given by the subcutaneous route. But please remember, don't only give low molecular weight heparin. You have to combine with oral warfarin also. Of course, oral warfarin will take few days for it to act. So what you have to do is you have to immediately start with low molecular weight heparin, but you continue giving warfarin so that over a period of time, over a longer period of time, this warfarin will take effect and protect from and protect the patient for further anticoagulation. I hope you're able to follow this, right? So for hemodynamically stable patient, you have to use oral anticoagulation. Anticoagulation initially heparin and along with the warfarin also. But some of the patients you may not take them up for anticoagulation. For example, there are some group of patients who have contraindication for anticoagulation, like a patient who recently underwent surgery, neurosurgery, or a patient who's having an intracranial bleed. If you use anticoagulation, what will happen? The bleed will further increase. All these patients, you cannot use anticoagulation. So now tell me, if I have a situation where it's again a hemodynamically stable patient, but that patient has contraindications for anticoagulation, what do you think I can use now? I cannot use any more anticoagulant because it's already contraindicated. What else can I use? What did I tell you? I should prevent any further clots from reaching from producing or from reaching the pulmonary circulation. What can I do? I can use something like this. See this picture? Any comments about this? What is that? Any comments about this? What is that? This is inferior vena cava. This is the pelvic veins. And below you have the lower limbs. What I can use? I can use something like this. What is that? Filter. I can use something like an IBC filter. What is the advantage? If I use the IBC filter, the clot can come to this level, but clot cannot go into the IBC. If it is not going into the IBC, it will not go into the heart, it will not go into the lungs. Are you able to understand this? So what can be used as a prevention? It is like IBC filter has to be used. Are you able to follow this? So very simple. IBC filter can be used. So hemodynamically stable patient, anticoagulant should be used. And if in a hemodynamically stable patient, there is contraindication for anticoagulation, I have to use an IBC filter. I hope you're able to follow this. Everyone able to follow this? Very good. Okay, so this is for a hemodynamically stable patient. Then moving on to hemodynamically unstable patient. What is the meaning of hemodynamically unstable patient? He is having large clots inside his body. So what should I do? I should go for removal or dissolution of the clot. So in this particular hemodynamically unstable patient, I should go for the removal of the clot or lysis of the clot. So what can I do in the treatment? Think and answer. For hemodynamically unstable patient, what can I give in the treatment? Any comments? What should I do? I can give something like a drug which can lyse the clot. What is that? Something called thrombolytic medications. Can anybody tell me a best example of thrombolytic or fibrinolytic medication? Any comments? Anybody? Thrombolytic or fibrinolytic medication? Previously, we used the streptokinase, urokinase, and all. But now we are not using a streptokinase as such, but we are using something called RTPA. I hope you can follow this. What is this RTPA? Recombinant tissue plasminogen agonists or activators. What is the typical example of that which we are using nowadays? Typically, what we are using is the altiplase or the retiplase. That is what we are using for thrombolysis. Altiplase or retiplase. This is what we are using for a patient who is having a large clot. Okay, yeah, there are so many things, doctor. Some of you saying retiplase also. That is correct. What we are using typically is the altiplase or retiplase. Now, very rarely, some of the patients, there are contraindications for thrombolysis also. Something like similar set of contraindication for thrombolysis also. So in that patient, what should I do? I should do a surgical procedure to remove the clot. Okay, it is not actually open surgery and something like with the catheter I can introduce and take out the clot. What do you call that? It is called embolectomy. It is called as embolectomy. Embolectomy. That's what should be used for a patient who's having contraindication for thrombolysis. This is the outline of management in a patient who is having pulmonary thromboembolism. So you divide it into hemodynamically stable patient and hemodynamically unstable patient. Our concept in a hemodynamically stable patient is that it is usually a small clot which the body itself will remove. So what I should do, I should prevent any further clot from reaching the pulmonary circulation. For that, I can use anticoagulation, or if there are contraindications for anticoagulation, I can use an IBC filter. That's all. But if it is a hemodynamically stable patient, it means there are large clots inside the circulation, which I have to remove it. For that, I have to use either a thrombolytic agent or with the help of catheter, I have to do the embolectomy, removal of the embolus. That is what you should remember as management for pulmonary thromboembolism. I hope this topic is clear because from this particular topic, I am expecting questions for the upcoming exams also. Okay, pulmonary thromboembolism is such an important topic which you should remember. I hope this is clear. Fine. Now only one more thing is left in the form of this particular thing, which is like a scenario I have put up. Just look at the scenario and try to tell me something related to this. Please look at the scenario, doctors, and try to tell me something. This is a patient who's a middle-aged male. He is undergoing treatment for sepsis. Okay, that is a gram-negative infection I'm writing. He was stable at the time of admission and showed improvement also after starting antibiotic treatment. On day 3, unfortunately, he develops a severe respiratory problem along with worsening of hypoxemia, and chest X-ray, which was initially normal, now shows diffuse opacities in the bilateral lung fields. What do you think is the diagnosis? So this is something like this. What is that? Till day 3, that means till this time, everything was going very smoothly for this patient. What is that? This patient had a severe sepsis or an infection. And as soon as we started antibiotic, this patient improved. Okay, and we were thinking this patient is improving trend only. But very unfortunately, all of a sudden, on day 3, he developed respiratory distress. He became very sick. An X-ray, which was initially normal, please remember the X-ray, which was initially normal, on day 3, now started to show opacities in the lung fields. So which do you think? Okay, this is a condition of sudden respiratory deterioration. This is a condition of sudden respiratory deterioration. Even during the COVID time also, deterioration. Even during this COVID time also, we had a lot of cases like this. The patient was initially doing well, but suddenly developed a breathing difficulty and expired also. Okay, in many cases. What is this condition called? This is a very, very dangerous situation, which all of you should be knowing about, called as ARDS. What is that? ARDS means something like acute respiratory distress syndrome. Acute respiratory distress syndrome. And for this condition to be diagnosed, we use a criteria called Berlin's criteria. This is something which is very important. Again, I'm putting a lot of stars here because this is something which has been asked in the exam frequently. Berlin's criteria. What does the Berlin's criteria tell you? It's a few points actually. Okay, there are a few points to tell that this patient is going in for ARDS. What is the first point? The patient shows worsening. The patient shows worsening, worsening in the form of respiratory distress within few days after the problem, within 7 days after an insult, after the primary insult. Okay, within 7 days after the primary insult. What is that? Primary insult may be anything. Primary insult may be like in the form of sepsis. Primary insult may be in the form of COVID infection. Primary insult may be in the form of pneumonia, trauma, anything like that. Any patient who had some other problem. Now, within 7 days, he is having a worsening of the respiratory distress. How it is going to occur? See, primary insult. Primary insult means a primary problem. It could be an infection, inflammation, something like that could have resulted in release of inflammatory mediators. Okay, that primary insult could result in the release of inflammatory mediators. And all these inflammatory mediators will come and target this particular area, What is this particular area of the lung which I'm drawing here? It is the alveoli. What can happen? All these inflammatory mediators can damage the alveoli like this. It can damage all the alveoli like this. Okay, whenever the alveoli is getting damaged, what are the cells which are lining the alveoli? It is nothing but the pneumatocytes. I think all of you must have heard this, pneumatocytes. And whenever there is pneumatocytes which will become damaged, okay, all the pneumatocytes will get damaged, what will happen? There will be leakage. There will be fluid leakage. There will be fluid leakage. So what is this condition which I'm trying to tell you? Lot of fluid gets leaked out into the blood vessels, into the lungs and all. It is basically pulmonary edema condition. That is what I'm trying to tell you. Pulmonary edema condition. Now, you can just tell me only one thing. What is the commonest cause of pulmonary edema we all know about? The commonest cause of pulmonary edema we all know about. It is heart failure. I think all of you should be knowing this. Heart failure is the commonest condition causing pulmonary edema. But is there any heart failure in this particular situation we are talking about? There is no heart failure at all. That is why this condition is called non-cardiogenic pulmonary edema. It's called non-cardiogenic pulmonary edema. Please make a note of this. It is called non-cardiogenic pulmonary edema. What is the basic reason for pulmonary edema then? It is due to damage to the alveoli caused by inflammatory mediators. So please remember, it is the damage to the alveoli of the pneumocytes caused by the inflammatory mediators causing all this non-cardiogenic pulmonary edema. So this is what is the important point about ARDS. Without a cardiac problem, there is pulmonary edema which is occurring. Second thing, when the alveoli is going to be damaged, will they take part in oxygenation properly? Not at all. So that is why this condition will result in what? Severe hypoxemia. It is going to result in severe hypoxemia. Okay. And how do you define this hypoxemia? We define the hypoxemia by a ratio called PaO2 divided by FiO2. What is the meaning of this? O2 is oxygen. What is this Pa? Pa refers to pressure in the artery, arterial pressure of oxygen. Fi refers to the inspired oxygen. Fi refers to inspired oxygen. And this value will be less than 300. This would be less than 300. What is the meaning? What is the meaning of less? Less means less arterial oxygen. What is the meaning? The amount of oxygen entering into the arteries is very, very less compared to what the patient is taking. That is obvious, correct? Because the oxygen will enter here. The oxygen will enter like this, but it will not enter into the body. Why? Because there is so much of damage to the alveoli, right? So what happens? You can give a lot of oxygen to the patient. However, the patient oxygen level inside the body will not improve. Very, very simple. That is what I am writing as PaO2 by FiO2 ratio, which will be less than 300. So it is typically reflecting in the ICU setting like this. What is that? You put the patient in ventilator, you keep on increasing the oxygen levels in the ventilator, but still the patient oxygen is not improving. Why? Because there is so much of damage to the alveoli. Are you to understand what I'm trying to tell you? Because the way by which oxygen can enter into the body is only through the alveoli. When alveoli is getting damaged, obviously oxygen will not enter into the body, how much ever oxygen you give it from outside. I hope now you're able to follow this. Clear? Okay. So that is what is the meaning of PaO2 by FiO2 being less. That is number 2. Number 3, what is the problem? Number 3, X-ray. obviously what is happening? There is so much of fluid leaking into the blood vessel. This would result in bilateral diffuse infiltrate. This would result in bilateral diffuse infiltrates. Both the sides, you will see a lot of infiltrates. Can you see that? Bilateral diffuse infiltrates will be present in the lung fields. Are you able to understand this? Why? It is basically due to fluid leaking out of the alveoli, causing a lot of infiltrates on the X-ray. That is number 3. Number 4 is very, very important. This is important for you to know. What is this number 4? Number 4 is the measurement of something called pulmonary capillary wedge pressure. Please make a note of this. Pulmonary capillary wedge pressure. What will happen to the wedge pressure? This will be normal. This will be normal. That is the point which I wanted to convey. Why I want you to know this normal pulmonary capillary wedge pressure? Because if the pulmonary pressure is increased, what does it tell you? If the pulmonary capillary pressure is increased, then we will say that this type of edema is not due to a pulmonary problem, it is due to a cardiac problem. Okay, if the pulmonary wedge pressure is increased, then it is called cardiac problem. Something like cardiac failure could have caused this edema. If it is not increased, it means it is the lung problem itself. Are you able to follow this? So please make a note of this. 4 important things in the Berlin's criteria. One is worsening of respiratory distress within 7 days after the primary incident. Second is hypoxemia, low oxygen due to alveolar damage. Third, lot of fluid leaking out from the alveoli, so there will be bilateral infiltrates on the X-ray. And fourth is the very, very important thing, which is called pulmonary capillary wedge pressure, meaning if the pulmonary pressure is increased, it indicates that there is a problem in the heart. If the pulmonary pressure is not increased, it means the problem is in the lungs only. That is what I'm trying to tell you. Just for your exam purpose, you just write what is normal pulmonary capillary wedge pressure. It is something which is less than 18 millimeters of mercury. That's all. That is what is called normal pulmonary capillary wedge pressure. Are you able to follow this? So please make a note of all these things, which are Berlin's criteria. What is this Berlin's criteria? Berlin's criteria is used for this particular condition of ARDS. That is what you should keep a note of. I hope you're able to follow this, right? So this is what you need to remember this about ARDS. It is a condition which you will encounter in the ICUs, where initially the patient may be looking normal, but within a few days, within 1 week, he worsens and develops a severe respiratory distress. That is what we call ARDS. Berlin's criteria helps you to diagnose that particular condition. I hope you're able to follow this, right? Okay, fine. So now, please explain in recording. I don't know which one to be explained in which recording. Okay, fine. So that is about the scenario part of ARDS, which I want you to remember. Last one is something like a question which came in this exam. Some of the students were having a confusion, so that is why to clear that confusion, I have put up this particular thing. Look at the question and try to tell me the answer. Look at the question and try to tell me the answer. Yes. You have a chronic smoker who develops blood-tinted sputum while coughing. While evaluation work, sorry, this question, please write it. Not workup is normal. Please write, change one thing. Chest X-ray is normal. Please write that. Chest X-ray is normal. Okay, while you are evaluating the patient, chest X-ray is normal. Which of the following should be the next step in evaluation of this patient? This was a question which came in this 2023 January exam. Any comments? Any comments? I think in the app, I'm not able to see this. It is just scrolling only. Just a minute. Yes, any comments, anybody? CT chest. Some of you are saying CT chest. Some of you are saying, okay, bronchoscopy. What should be the answer? See, first of all, I will tell you the, okay, first of all, I will tell you the, what is it? I will tell you the flow chart. How do we evaluate a patient with blood-tinted sputum while coughing? Then I will come to this particular question. This is a flow chart taken from Harrison textbook. Okay, what is this blood-tinted sputum with the while coughing called? It is nothing but hemoptysis. I think all of you know this. Now, this question basically asks you whether you know how to evaluate a patient with hemoptysis. See, whenever you have a patient with hemoptysis, you should classify them into 2 categories. One is a patient who is having a non-massive hemoptysis. Another one is a patient who is having massive hemoptysis. Massive means so much of blood is lost. Somewhere around 1 liter or more than 1 liter of blood is lost. We call it massive hemoptysis. See, nobody can measure the amount of blood lost through coughing and all. Okay, so what do? We look at the vital parameters. Okay, if he is an unstable patient, for example, the patient has features of shock, something like that, then we call it as a massive hemoptysis. This usually is your question. They used to ask, you have a patient who is presenting to the emergency room with massive hemoptysis. What should be your immediate management? Anybody can answer this? Anybody can answer this? What should be the immediate management? First thing, you have to protect the airway. Maybe like you can put endotracheal tube or all those things. You have to protect the airway in that patient. Second thing is that you have to go for control of the bleeding. You have to go for the control of the bleeding. Control of the bleeding. Any idea whenever a patient is having hemoptysis, okay, which artery could have been the bleeding source? There are only two important bleeding, so there are two important arteries applied to the lungs, which you will remember. One is the bronchial artery, other one is the pulmonary artery. Where do you think the bleeding could have started from? Bronchial artery or the pulmonary artery? Most commonly, it is the bronchial artery. So what you should do for this patient? You should do something called embolization. You should do something called embolization, where you will embolize the bleeding artery. Okay? Bronchoscopically, you can do this embolization. That is what you have to do. Dr. Tranexamic acid can help, but for a bronchial artery, it is better that you go for embolization. This is what, according to the Harrison. So you can do the scopy, and then with the help of the scopy, you can do something called embolization of the bleeding artery. That is what is done generally for a massive bleed. But if it is a massive bleed, if it is a non-massive bleed, we go to the other thing. Okay, if it is a non-massive bleed, then you assess for high risk. Assess for high risk. Whether the patient is a high risk patient or not. What are the high risk factors which will be telling you that the patient is high risk? One is the age. One is the age more than 40 years. Second, anybody wants to come in? Chronic smoker. Can anybody tell me if this is going to be the situation, like age more than 40 years and or a chronic smoker and all? That means he's having risk factors. What do you think is the situation commonly? What do you think is the situation? It is usually something like which condition you will suspect? Age more than 40 years and he is a chronic smoker. You will think about a cancer. You will think about a cancer in that particular condition. For that only, you have to first do X-ray. First, you have to do the X-ray. First, you have to do the X-ray. Of course, you can do the blood testing and all, but imaging, you have to first do X-ray. And if normal, it can be normal also. Not in all cancers, you will have a positive X-ray. That is what the situation we are dealing with also. What is that? If normal, you have to next go. That was the question. What is that? You will do a CT scan or you will do a bronchoscopy. You have to do a CT scan. Very, very simple logic. First, we have to find out which area there is a bleeding manifestation, correct? Or which area the problem is occurring. It should be CT scan which should be done, because CT scan only will tell you whether it's a right-sided lung or a left-sided lung which is having the problem. Then if the CT scanning is able to pick up which side of the lung is having the problem, then you can go for bronchoscopy and then you can decide further. Are you able to follow this? So this is what I want you to remember. The sequence is like this. Number one will be the chest X-ray. Number two will be the CT scanning. And after CT scanning only, you have to go for bronchoscopy. This is what Harrison textbook says, and that is what we follow clinically also. First, the X-ray. If normal, go for CT scan. CT scan will tell you which side, right side or left side. Then you can go for the bronchoscopy. Are you able to understand what I'm trying to say? Okay, right. If there are no risk factors, think like the patient is 30-year-old patient, he is not a smoker and all. Okay, he is not a smoker and all. Then what you can do? This is probably not a cancer and all. You don't need to do the X-ray, CT scanning and all. It could be probably, please write it, it could be probably a infection. It could be probably infection. What is the typical infection which can be associated with this blood in sputum and all? It is probably something like bronchitis. Something like a bronchitis only. So what you can do is you can give antibiotics and then ask the patient to come again. That's all. You can give antibiotics. Are you able to understand this? So this is what you need to remember. This particular pathway is something which you have to remember very, very correctly. Okay. First thing, foremost thing is you have to assess whether the patient is having a massive bleed or a non-massive bleed. If it is a massive bleed, don't think about anything else. You go for protection of the airways by, for example, intubation and all, and then you do the bronchoscopy, and then you have to control it with the embolization. That is the point to be noted. And what is the next one? Non-massive bleed. That means his vitals are stable. Then you look at the risk factors. If risk factors are present, go for X-ray, CT scan, and bronchoscopy in that orders. If there are no risk factors, okay, then it is probably an infection only. You can give antibiotics and you can reach with the patient. That is what is the scheme of evaluation for hemoptysis in a patient. Based on this, question had come. So now look at the question again. A chronic smoker develops blood in the sputum while coughing. While evaluation, chest X-ray is normal. That means we have already come to this stage. Chest X-ray has become normal. When the chest X-rays become normal, what should be the next step in the evaluation? Obviously, the next step will be CT scanning. Are you able to follow this? The answer for this question is going to be option B. Sorry, option C, CT chest. Are you able to understand this, doctor? This was a very recent question, so that is why I have included at the end of the discussion. Okay, right? The same pattern of question can be asked. Usually, all your previous exam questions were like massive bleeding. What is the management, like that was asked? But now it is a non-massive bleeding, and they have already given chest X-rays normal. The next step is going to be CT scan. Okay, so that will be about the discussion for today. And as I told in the beginning itself, written notes I will not be able to share because I have already shared the workbook. I think well in advance with your coordinators also. They have actually sent the workbook to all of you. So written notes as such I will not be able to share. But please try to get the workbooks and try to fill it up. Okay, that's what I can say. So tomorrow we'll start at the same time. 9 o'clock we'll start. I will send over some important MCQs also related to the today's discussion. I think the evening class has been cancelled. I think orthopedic class has been cancelled for you. So you have time, refresh for some time, and then again you read about this particular chapter today itself. Try to read most of the chapters today itself, and then go through the question which I'll be sending you in few hours. And tomorrow when we start the discussion, we will start with the questions first. Okay? All right? Okay. Yeah, I do understand that some of you are having the tab only, and that is what they have informed that you should be able to take the printout and write it. Okay, you should take the printout of that material and you can write on that only. Okay, right? Fine. That is the reason for providing the workbook also, Doctor, to make you write in that material. Okay, to make you write in that material. Okay, fine. So thank you, and I'll see you in the tomorrow session. Okay, so tomorrow the discussion will be about neurology. Okay, neurological disorders, obviously a very important one for your exams. Will be discussed over 1.5 days. Tomorrow I will not be completing neurology. Most of the neurology will be completed tomorrow, and a small part will be left for the day after. Okay, fine. All right. So I'll see you tomorrow in the discussion. Okay. Bye.